Morning, everybody. We are going to get started with our conference. Welcome to Facing Heterotaxy Together. This is the first ever virtual conference uniting physicians, scientists, clinical care providers, patients, and families with heterotaxy. My name is Tom Saba, and I'm a pediatric pulmonologist at the University of Michigan. And on behalf of my conference co-chairs, Dr. David Shidlow from Boston Children's Hospital, Dr. Stephanie Ware from Indiana University, and Nisha Sabin, Executive Director of Heterotaxy Connection. We sincerely thank you for joining us today, and we want to extend our gratitude to all those who are presenting this morning and tomorrow, all the families that are presenting their experience with heterotaxy, and for all those who have devoted time and hours and research and a sincere commitment to helping children and families living with heterotaxy. I'd like to now introduce Nisha Sabin, Heterotaxy Connection Executive Director, President, and Co-founder, to tell us a little bit about Heterotaxy Connection, and then I will give you a few more details about how the rest of the conference is going to unfold.
Thanks, Tom. Good morning, everyone, and thank you so much for coming today. Heterotaxy Connection aims to enhance diagnosis through comprehensive education, both for patients and medical professionals, to empower people with heterotaxy by collaborating closely with medical community, to establish a network of centers of excellence, to fuel ongoing research through the creation of a patient registry, and to support the development of treatment protocols, ensuring accurate and timely care for heterotaxy patients globally. Heterotaxy Connection was founded in 2014 by a small group of moms who wanted to make a difference. We are a 501c3 nonprofit. Back then, there wasn't much information available. My daughter didn't receive her diagnosis until she was 7. It was often a very dark, lonely road as we tried to figure out and understand her complex needs. It wasn't until we had her official diagnosis that I quickly saw the power in being able to connect with others fighting similar battles. I realized the power in being able to connect and the lack of an existing community to do so. We've grown from just a few families to a global network of over 2,100 people, all from all over the US, Canada, and 25 plus countries, dedicating to empowering families and advancing care. We have support groups, held multiple family conferences, host heterotaxy awareness and remembrance days, helped compile a consensus paper that was released 2 years ago, and continue to work with doctors and professionals to bring heterotaxy to the forefront. Today, we are thrilled to be co-hosting the first ever Heterotaxy Scientific Conference with the Heterotaxy Research and Clinical Care Collaborative. This event represents a critical step forward for our community as we bring together medical professionals and researchers to exchange knowledge, foster collaboration, and inspire new approaches to diagnosing and treating heterotaxy. Unless you have had a doctor to pull out their phone to Google your child's condition in front of you, or had a surgeon call you from an OR to confirm that what they're seeing is really what is right, while your child is opened up, it's hard to convey what it truly means for our community. Some of the words that have been mentioned are hope, knowledge, camaraderie, connected, and supported. As parents of a child with heterotaxy, the rarity of this condition often makes us feel isolated, like we're navigating uncharted waters alone. Having a scientific conference dedicated to heterotaxy for the first time is incredibly meaningful. It means our children's complex needs are finally being recognized and discussed by experts. For the first time, we feel like our voices are being heard on a larger scale, and there is real hope for better understanding, research, and treatments that can make a difference for our families. Heterotaxy Connection is grateful to the doctors that have come together to help make this conference happen, and hope that you take something away that will help you with the next heterotaxy patient that you see. We are grateful for your participation and hope this conference strengthens our collective ability to provide accurate, timely care to heterotaxy patients worldwide.
Thank you, Nisha. And again, thank you to Heterotaxy Connection and all the patients and families who have been involved in advocating for their children and teaching us doctors professionalism and empathy, and helping us to learn how to build clinical programs to help these patients. Similarly, the Heterotaxy Research and Clinical Care Collaborative is a group of physicians, scientists, and clinical care providers who want to support clinical, translational, health sciences, and basic science research, help build clinical and research networks around the country, help support the development of clinical centers of excellence, at various hospitals around the country and eventually help develop a registry for heterotaxy. The goals of this particular conference are to offer a multidisciplinary approach from various subspecialties. Some people on this call, some presenters might actually have different opinions on things. And that doesn't mean that we're unsure about how to do it. It just means that this is an opportunity to grow, learn, do some research, do some scholarship, and find the true right answer one day. All the opinions shared today are evidence and expert-based. If you hear something that sounds a little bit unusual, feel free to bring it back to your doctor and talk about what's right for your child. None of the opinions shared today should be taken as strong medical advice for your own child. The conference itinerary is available on our websites, either Heterotaxy Connection or HRC3. You can follow along what the itinerary looks like for today and for tomorrow. The conference, although the numbers of participants are not quite up there yet, over 250 people have registered to be a part of this conference. This includes various subspecialists in pediatrics and adult medicine, cardiology, pulmonology, immunology, hematology, critical care, neonatology, etc. These are people from research fields, clinical care fields, and from all over the world. We have registrants from the US, Canada, Ireland, New Zealand, Great Britain, Italy, Israel, and Saudi Arabia. A truly global conference indeed. If you have questions that you'd like to ask to any of the presenters, please feel free to write those questions into the chat. We will address those questions during the question and answer period this afternoon at 12:30 Eastern Time or 12:30 tomorrow Eastern Time as well. If you are a parent or a patient, please also feel free to ask some questions. We have one additional hour at 1 p.m. this afternoon, during which the experts will stay on the call and help patients and families get some of their own personal questions answered. The conference etiquette is that we would like everyone to remain muted and please only unmute if you're a presenter or if you're answering a question. This is an inclusive environment. We do not tolerate discrimination, harassment, or disrespect. After the conference, the entire conference proceedings will be recorded and the video will be available on our respective websites. We will probably also publish a conference proceeding in a peer-reviewed journal. And if anybody wants to be involved in our work on Heterotaxy Connection or on the Heterotaxy Research and Clinical Care Collaborative, we would love some help. We have multiple different working groups looking at research, clinical center development, website development, developing conferences, developing a registry run one day, fundraising. There's a lot of work to do. If you'd like to be involved, we will offer information at the end of the conference on how you can reach out to us. We would love some help. Without further ado, I will introduce our first speaker. Let's start with the basics of defining heterotaxy. Dr. Stephanie Ware is an MD, PhD, a professor of pediatrics and medical and molecular genetics, and vice chair of clinical affairs in medical and molecular genetics, as well as the program leader in cardiovascular genetics at Indiana University. Dr. Ware.
Everybody, I wanted to extend a special thanks to Tom and to Dave and to Tunisia and everyone who's worked so hard to make this conference happen. I'm really looking forward to the next 2 days.
Paula, the volume is very low.
So much define laterality is hopefully bring up a couple topics of interest and to begin to frame a conversation that I hope will carry on after the meetings over the next 2 days. So to start, I just want to remind everyone that laterality really starts during early embryonic development before the organs are formed, and it occurs initially at an early embryonic structure, the left-right organizer, and cilia are very important for this process, in particular embryonic nodal cilia. And this is the reason why we see this association between primary ciliary dyskinesia and heterotaxy, and as well between some types of isolated heart defects and cilia potentially. So of course, heterotaxy is fundamentally a disorder of left-right asymmetry. And so we see abnormal arrangement of thoracic or abdominal organs relative to the left-right axis. And then also typically cardiovascular malformations that would be consistent with abnormal heart looping during development. And those are frequently coupled with multiple congenital anomalies. So in the picture here, you see situs solidus on one end of the spectrum and situs inversus on the other end of the spectrum. And then, of course, you can get multiple different arrangements of the visceral organs during this left-right patterning process. So there have been a lot of names used to describe different parts of left-right patterning and laterality. So situs inversus totalis, visceral situs inversus thoracic situs inversus, and then heterotaxy, as I've mentioned, visceral heterotaxy, visceroatrial heterotaxia. So there are some questions then, are we talking about the same thing? If we say visceral heterotaxy and we say visceral situs inversus, there's left isomerism, left atrial isomerism. Are these used interchangeably, or do they mean something different from each other? And this is where, while they have developed to try to help us be more precise, I think we need to be very clear about the anatomy when we're talking with other individuals to make sure that we're on the same page. Then you get into the asplenia, polysplenia syndrome, Eibmark syndrome, other terminology that you see here. Also, the embryologic terms, left-right patterning, embryology C-loop, S-loop of the heart, or just more generic looping. And that's before you even get into beginning to talk about segmental anatomy and the different nomenclature that goes with that. And then finally, situs ambiguous viscerum. So this can all be very confusing. And I think there has been a tendency for subspecialists to sort of focus on their organ system and the nomenclature related to their organ system. And so it can be a bit like this picture where everyone is describing the same thing, but it's described a little bit differently depending on what your area of specialization is. However, I might suggest that in some ways it's even a little bit more extreme, where we're all kind of dealing with our particular part of the elephant and not even really communicating to each other that often or that frequently. And so I think that this has some potential for not being the optimal patient care, and we can strive to do a little bit better than this. And so just as an example of some of the miscommunication or misperceptions that can occur, I'll give an example from myself. I had been working in the laboratory on the developmental biology of left-right patterning for some time, several years, and had been seeing heterotaxy patients in clinic for several years at the time this paper came out. And so this is a really nice study on the epidemiology of laterality defects. And it was done by Angela Lin, who's really very well respected in the field for her deep phenotyping abilities and for her knowledge, both as a geneticist and as a cardiologist. And the National Birth Defect Prevention Study is a national epidemiology and environmental risk factor study that occurs in 10 parts of the United States and had been collecting data for 30 years. And so it was a really good opportunity to describe laterality cases. And so when this paper was published, I really avidly dug into it. And this table really sort of stopped me in my tracks because in all of my kind of work, I had always described situs inversus totalis as the complete mirror image. So to me, that meant that the patient did not have any structural cardiac abnormalities, had dextrocardia, but structurally the heart was normal. And if the heart was abnormal, then that almost by definition was heterotaxy. And so I quickly noted here in the birth defect prevention study that almost 40% of the patients with situs inversus totalis had some type of congenital heart defect. And so this is actually the table from that study where they have defined heterotaxy. And we now use this definition, although a little bit more loosely in a number of the studies that we're doing. This is a very nice definition, but it is fairly stringent in that heterotaxy requires at least 3 features from groups 1 to 8 here. And group 1 is a fairly extensive list of characteristic congenital heart defects. And then you have the morphology of the atrial appendages, as well as the venous anomalies treated separately. And then beyond that, you have the other organ systems that we commonly see with sightedness differences in heterotaxy. So is it heterotaxy? Tom and Adam Shapiro really drove this paper that came out a couple of years ago now for a comprehensive approach to management of children with heterotaxy, which I think is very much needed. The question, though, is are all of the patients going to get the management they need if we don't have a very solid definition of what to include in heterotaxy? So I think we would all agree that an unbalanced AV canal, interrupted IVC, epiarterial bronchi, asplenia, right-sided stomach, midline liver would be someone considered to have heterotaxy. But what about someone with complex congenital heart defects, including LTGA and DOR, but normal situs of liver, spleen, and stomach and a malrotation? Are we going to call that heterotaxy that only has 2 organ systems involved? Or what about an even more simple heart defect, ASD, and a left-sided liver and the other anatomy not yet defined? Finally, take the case where there's no congenital heart defect, maybe a 4-year-old who had a volvulus and went to the OR, found to have malrotation, and also multiple splenials were noted at that time. So polysplenia got put into the electronic medical record. Is someone going to call this patient heterotaxy, and do they need more of a diagnostic workup? So I think these are important questions for us to deal with, and they're important from a research standpoint because we would like to have more precise coding. We also would like to be able to make sure our inclusion criteria are standardized and that we have good registries, the good ability to do natural history studies and outcomes. But more importantly, from a patient care standpoint, I think if we are not able to do this well, then there's a possibility for missed or delayed diagnoses. And certainly in talking with patients, I've heard this multiple times of them, not knowing that they had an immune deficiency until they were in their 20s, for example. And then just in terms of the patient family experience, we risk these diagnostic surprises. Some isolation where families are told that they have never seen that anatomy before, where in reality they could be told, oh yes, this is part of heterotaxy spectrum. And it means that we're requiring the families to really develop the medical sophistication and advocacy across specialties rather than us being proactive in doing that. So hopefully this will give us some things to think about as we go forward over the next 2 days. And I very much look forward to all the discussions.
Thank you, Dr. Ware. As we learned, there are various definitions of heterotaxy, and the actual anatomy of the heart can be quite complex in children with heterotaxy. I now want to introduce Dr. Emily Buchholz, MD, PhD, and Dr. Steve Spurgeon. Dr. Buchholz is an assistant professor of pediatrics in the Division of Cardiology at the Children's Hospital of Colorado. Dr. Spurgeon is an assistant professor of pediatrics in the Division of Cardiology at UT Southwestern Children's Medical Center. Drs. Buchholz and Spurgeon. The sound is not working.
Hello and welcome. We are excited to now break into a focused talk on the cardiac manifestations of heterotaxy syndrome. We will start with a basic review of the right and left atrial isomerism, outline the common cardiac manifestations seen in patients with heterotaxy syndrome, discuss the limitations of the current nomenclature, review how the cardiac manifestation of heterotaxy affect overall outcomes, and discuss a few specific high-risk cardiac complications we know to be associated with poor outcomes. The So building on Dr. Weir's presentation, as we launch into the cardiac manifestations of heterotaxy syndrome, I want to highlight again what happens to sightedness in heterotaxy. So taking this picture of our hospital with right and left assigned as we would assign them on a chest x-ray, if you just flip the picture, you get sinus inversus. If, however, you duplicate the right side onto the left, or duplicate the left side onto the right, you get the two subtypes of heterotaxis, right isomerism and left isomerism. Fundamentally, heterotaxy is a duplication of sightedness, not inversion. But with that in mind, when trying to diagnose or classify heterotaxy, for each organ, we can ask several questions. What side of the body does it belong? Does the organ have a unique left and right side? And for our presentation, we want to specifically consider the question, what is the left and right side of the heart? How should we define it? Classically, cardiac isomerism is described in terms of the morphology of the atrium, and specifically the atrial appendages. The right atrial appendage is broad-based, with pectinate muscles extending out into the atrium itself. The left atrial appendage is more narrow and finger-like, with pectinate muscles confined to the appendage. Meanwhile, in right atrial isomerism, you have bilateral, morphologically right-sided appendages, with pectinate muscles surrounding the entirety of the adjacent atrioventricular junction. In left atrial isomerism, you can see how the finger-like left atrial appendage is duplicated on the right, with pectinate muscles confined to the appendage. Now, it's all well and good to focus on the atrial appendages, as they are a useful reflection of the atrial sightedness, but they are a very small part of the heart. So let's take just a minute to examine the sightedness of normal cardiac structures so that we can view them as clues to the overall pattern. In a normal heart, the superior and inferior vena cava should be intact, returning venous blood to the right side of the heart. The pulmonary veins should all return oxygenated blood to the posteriorly located left atrium. Two separate valves should separate the atria from the ventricles on either side of the heart, while the outflow from the right and left ventricles should also be separate and coming from the appropriate side. Finally, the electrical hardware should be in its place in the right atrium with single SA and AV nodes. However, when sightedness is duplicated, all bets are off. The hepatic portion of the inferior vena cava, the right-sided structure, is typically interrupted in left isomerism. The pulmonary veins of left-sided structure often exhibit highly variable and anomalous return in right isomerism, as the right atrium has been duplicated, as it were, onto the left. Presence of the SA node and AV node in normal right atrial tissue sets up the possibility of dual AV nodes when right isomerism occurs, as well as heart block when left isomerism is the problem. But interestingly, the critical function of the heart, pumping of blood to the lungs and the body, is most drastically affected by right isomerism, which has higher rates of single ventricular heart disease, as well as abnormally located or narrow outflow tracts or great vessels. While the laterality of multiple organs is affected, the diagnostic focus has been on the atrial and splenic anatomy. And I think that makes sense when you consider the clinical workflow and how the technology has progressed. You start with a chest x-ray, you see the heart or stomach in the wrong place, and then get an echo and an ultrasound, and the atrial appendages and splenic anatomy are the things you can see next. But with increasing utilization of cross-sectional imaging, CT and MRI, we can get more anatomical information on the lungs and abdominal organs and really hash this out. But as often happens when you get more information, it tends to confuse the issue a little bit further. So this retrospective review of cross-sectional imaging in heterotaxy patients showed that a decent number of patients just don't stay in their lane. It turns out that about 20% of the time, both right and left isomerism are seen in different organs in the same patient. The patient whose images are shown here have atrial situs solidus, bronchial right isomerism, and abdominal left isomerism. Which, returning to our example using the photo in Children's Hospital, would look something like this. So the take home here is that even if we diagnose clear left atrial isomerism, we have about a 20% chance of being wrong about what lies below the diaphragm. And this risk of disharmonious patterning may underlie some of the variability in anatomy. This table shown here comes from the echo textbook that all pediatric cardiology fellows use. It summarizes the various case series of heterotaxy patients that have been published to compare the incidence of cardiac anomalies that are seen in the asplenia and polysplenia phenotypes. It shows only one anatomical characteristic that is not shared with both groups of patients. An interrupted IVC is a very strong clue for left cardiac isomerism. For that reason, I'll take a few moments to share my understanding of why this is so. On the left, you see the primitive venous vasculature in the developing embryo. As development progresses, the complex and coordinated regression of some of these veins occurs, leading to the mature venous system you see here right. Looking back, we see a difference in the left and the right sides of these veins at the level of the liver. So if you have left isomerism, duplicate that left side absent of onto the right, we will impair the development of some part of the hepatic or suprarenal segments, leading to an interrupted IVC. In this case, the venous drainage of the lower body has to go through the system shown here. And as we lean on advances in cross-sectional imaging, we can look for new ways to phenotype left and right isomerism, like this study, which has given us insight into the lymphatic drainage patterns. This study included patients with right and left atrial isomerism, as well as pulmonary and abdominal sinus inversus patients with congenital heart disease. In 56 patients for whom the terminal thoracic duct was visualized, they found that the SVC and aortic arch sidedness were independently associated with terminal thoracic duct sidedness. But you can also see that left or right atrial isomerism did not seem to predict or be associated with the thoracic duct drainage anatomy. So next, we're going to switch gears and talk about the cardiac outcomes in heterotaxy.
Excellent. So for those of us who take care of patients with heterotaxy, it should come as no surprise that these patients have among the highest mortality risk of all patients with congenital heart disease. This particular Kaplan-Meier curve compared 10-year survival in patients with single ventricle heart disease at the Mayo Clinic over 5 decades. Heterotaxy is shown in dark red, and other forms of complex congenital heart disease are shown in other colors. They found an overall 10-year survival rate of 78 to 85% in patients without heterotaxy, but in patients with heterotaxy, survival was closer to 65%. But why do patients with heterotaxy do so much worse? We can start by asking, when is the highest risk period of time in these patients? From this image, you can see that the greatest drop in survival occurred early on in the immediate postoperative period, and then there was this slow decline in survival over time. Indeed, other studies have shown this to be true as well. These data are from a case series of 366 patients that looked at timing and causes of death in patients with heterotaxy undergoing cardiac surgery. They similarly identified that around 60% of the deaths occurred in the immediate postoperative period. Sudden cardiac death, likely due in a large part to arrhythmias, represented about 20% of deaths, cardiac non-surgical deaths 11%, and non-cardiac causes only 8%. When we dig a bit more into the perioperative mortality rates in heterotaxy patients, there's data from the Society of Thoracic Surgery database that demonstrates higher mortality rates for patients with asplenia, shown in light blue, across all preoperative STS risk categories as compared to patients without heterotaxy, that's shown in green. Polysplenia, shown in dark blue, was more of a mixed bag depending on surgical risk. And then among patients undergoing single ventricle palliation, shown over on the right, patients with heterotaxy had higher postoperative mortality after both the index shunt and the Fontan operations. These data would suggest that there's something independent of the severity of the heart disease that places patients with heterotaxy at increased risk in the postoperative period. We know that patients with asplenia appear to be a particularly high-risk group. And indeed, studies have consistently shown that patients with asplenia have higher mortality or lower survival, as shown on these curves, as compared to patients with polysplenia. You can see that the survival curves separate early on and then remain separate, suggesting again that the perioperative time period is the highest risk time for patients with asplenia. But what about asplenia makes these patients such high risk? I'll take you back to that summary that Steve showed. Recall that in asplenia, the pulmonary veins are often anomalous with or without obstruction. Atrioventricular canal defects are common and are often right or left dominant, favoring one ventricle. And there's often a single outflow tract due to pulmonary stenosis or atresia. And as a result, single ventricle heart disease is much more common in patients with asplenia than polysplenia, with most case series reporting a 2 to 3-fold higher risk of single ventricle heart disease in patients with asplenia. And it should come as no surprise to this audience that patients undergoing single ventricle palliation have worse long-term survival than those undergoing biventricular repair. So this Kaplan-Meier curve comes from the Toronto experience, where they looked at patients with left atrial isomerism and a normal heart, shown in the top curve, those with a heart suitable for biventricular repair, and those with a heart suitable for single ventricle palliation. And they found that patients with single ventricle palliation had the worst survival over the long term. What also strikes me about this graph, though, is that even among those with normal hearts, the heart yearly mortality rate was quite high, presumably due to extracardiac disease. As a follow-up study, the Mayo group looked at their own institutional data and divided their cohort into poly versus asplenia and single versus biventricular repair. And they found that polyasplenia patients with biventricular physiology had the best survival, and that asplenia with single ventricle physiology had the worst survival. Polyasplenia with single ventricle heart disease was somewhere in between. And in this particular cohort, there were insufficient numbers of patients with asplenia undergoing biventricular repair to model that curve. So what about other risk factors? These data come from a cohort of approximately 260 patients followed at Boston Children's Hospital, which looked at risk factors for death over a median of 10 years. They found that the highest risk was conferred by the presence of acquired pulmonary vein stenosis after total anomalous pulmonary venous connection repair, univentricular circulation, mild or greater atrioventricular valve regurgitation, and the asplenia phenotype. And if you recall, these risk factors are also more common in right atrial isomerism, TAPVC, single ventricle physiology, and common atrioventricular canal defects, which are at increased risk of valvular regurgitation. And these same risk factors have come out time and again in other patient cohorts. The same study also performed a CART analysis, which I found particularly interesting, to look at interactions and risk factors. I like the schematic because they were able to identify that the highest risk group, shown here in red, and the lowest risk group, shown in blue, patients with a combination of a univentricular circulation and TAPVC have the highest mortality of around 71% over 10 years, compared with only 11% in patients with polysplenia and a biventricular circulation. But what about other risk factors aside from structural heart disease? Increasingly, heterotaxy is being recognized as a form of ciliopathy and often co-occurs with primary ciliary dyskinesia. This study looked at respiratory complications in patients with heterotaxy with and without ciliary dyskinesia who were undergoing cardiac surgery. And they found that patients with heterotaxy were more likely to experience respiratory complications, defined as things like failed extubations, respiratory failure, respiratory infections. They were more likely to have respiratory complications and to require inhaled beta agonists after surgery. Studies looking at infectious risks after surgery found that patients with heterotaxy have a higher long-term risk of community-acquired severe bacterial infections, but not nosocomial infections, as compared to other patients with complex congenital heart disease. So the study on the left compared community-acquired SBIs in patients with heterotaxy to those with complex congenital heart disease, but no heterotaxy, and found that the 2-year cumulative SBI rate in heterotaxy was almost 10% in patients with heterotaxy, compared to basically 0 in complex congenital heart disease. The graph on the right comes from a separate analysis of the same cohort, which examined nosocomial infections after cardiac surgery and found a comparable infection rate in both patients with congenital heart disease with and without heterotaxy. The most common causal pathogens in both groups were coag-negative staph, enterococcus, and gram-negatives. We also know that patients with heterotaxy are at high risk of arrhythmias, which may explain the high rate of sudden cardiac death in these patients. In this study, about 35% of patients with right isomerism and 51% of patients with left isomerism had arrhythmias by age 20. The most common arrhythmia in right isomerism was SVT, whereas in patients with left isomerism, it was paced bradycardia, either due to sinus node dysfunction or atrioventricular block. And we'll talk more about this in a bit. And then finally, some may ask about heart transplantation outcomes in this population. These data come from the UNOS database, in which the authors looked at waitlist duration and graft survival by indication. So the analysis included 140 patients with heterotaxy who underwent cardiac transplantation and compared outcomes to patients with congenital heart disease, but no heterotaxy, and those with cardiomyopathy as the primary indication. Median time on the wait list for heart transplant was significantly longer, about 91 days for heterotaxy compared to 63 days for congenital heart disease and 56 for cardiomyopathy. And while early outcomes were similar, the 5-year graft survival after heart transplant was lowest in patients with heterotaxy, 69% versus 78% in congenital heart disease and 87% in cardiomyopathy.
So to wrap things up, we wanted to spend a few minutes discussing 2 fascinating high-risk cardiovascular complications that occur in heterotaxy syndrome. Here is a selection of pulmonary angiograms of patients in the Glenn stage of single ventricle fibrillation. And the question here is, can you pick out the patients just from looking at these pictures with interrupted IVC and left isomerism? Well, even without an echocardiogram, it's a good bet that these are your left isomerism patients, because they tend to get the worst of pulmonary AVMs during the Glenn stage. So we know that among patients with single ventricle congenital heart disease, those in the Glenn stage are at clear risk of pulmonary AV development. Clinically, they present with progressive and severe desaturation. angiographically, we can pick up on the severity of pulmonary AV shunting using the pulmonary capillary transit time. When you compare the transit times of a bunch of blend patients, the ones with the most drastic pulmonary AVM are invariably those with interrupted IVC and left isometers, seen on the bottom right, compared to the angiogram on the top right, which is a patient that does normal garden variety with ventricle epitest. This has been reported multiple times over the years, including these nice studies showing freedom from pulmonary AVMs with a Kawashima, with the vast majority of patients developing pulmonary AVMs by age 8 to 10. As such, there's been a push to perform earlier front-end completions in all patients who undergo Kawashima operations in order to hopefully avoid the long-term complications associated with these severe AVMs, which dramatically increase morbidity and mortality.
But what about conduction system abnormalities? If we return to this table showing the distribution of arrhythmia types and different subtypes of isomerism, recall that SVT was the predominant rhythm abnormality in right atrial isomerism, and bradycardia, either due to sinus node dysfunction or AV block, was the most common in left atrial isomerism. But why is this the case? In general, and there are always exceptions to the rules, patients with right atrial isomerism tend to have duplicated sinus nodes or AV nodes because the atria are often mirror images of the right atrium. This redundancy in sinus and AV nodal tissue can lead to a propensity for supraventricular tachycardias, including twin AV node tachycardia. In contrast, those with left atrial isomerism have mirror image left atria, and therefore often lack normal sinus and or AV nodal tissue, leading to a propensity for sinus node dysfunction and or AV block. The data on the right are from a remarkable autopsy study from 2012, where they looked at the presence of sinus and AV nodal tissue in patients with heterotaxy. In right atrial isomerism, they found bilateral sinus nodes in over half of the cases. In left atrial isomerism, 8 out of 8 cases had no sinus node in their right atrium because it was not a right atrium, rather a morphologic left atrium. 5 of the 8 had normal sinus node architecture, but located in the left-sided atrium, and the remaining 3 had either absent or hypoplastic sinus nodes. As a result, it's not surprising that the most common arrhythmia in right atrial isomerism is SVT, either due to an ectopic atrial focus or twin AV node tachycardia. The EKG on the right shows the transition between 2 automatic foci in the atria that have different P-wave morphologies and are competing with each other for dominance. You can see the downward deflection of the P-wave in atrial rhythm 1, which transitions to an upward deflection in atrial rhythm 2 because there are 2 separate foci originating from 2 different parts of the atria. And just like different P-wave morphologies, you can also get 2 discrete QRS morphologies when there are twin AV nodes present. Depending on where the initial stimulus arises, one of the 2 AV nodes will be activated and the resultant QRS complex will be generated on the surface EKG. And with the presence of 2 AV nodes, the risk of creating a reentrant circuit between those nodes is quite high, leading to AV nodal reentrant tachycardia. Hence, patients with right atrial isomerism are at increased risk for fast arrhythmias due to duplication of the conduction system and the potential for reentrant circuits. But what about left atrial isomerism? Again, in left atrial isomerism, the sinus node can be normal, present in a different location, absent, or hypoplastic. So the rhythm strip on the right shows a normal sinus P wave on the top and an ectopic P wave coming from a different part of the atrium on the bottom. You'll immediately know that the ectopic rhythm is slow because the foci isn't, or the focus isn't coming from the sinus node, and the P wave is inverted in lead 2. And finally, because patients with left atrial isomerism can have abnormalities in the structure of the AV node, they are at high risk for the development of complete heart block. On the EKG on the right, you can see complete dissociation of P waves representing atrial contraction and QRS complexes representing ventricular contraction. High-grade AV block can present in utero or later on in life. And actually, in one study, a third of fetuses with left atrial isomerism had complete heart block in utero, and it was the leading cause of mortality prenatally. So many of these patients will go on to require pacemakers. So I hope from our talk today, we've been able to convince you that complex congenital heart disease is quite common in heterotaxy. Current classification systems, including right atrial and left atrial isomerism or asplenia, polysplenia, are incomplete. Heterotaxy patients are at high risk of death and cardiac complications, both postoperatively and over the long term. And there are unique features of the cardiac anatomy that predispose patients to long-term complications.
Really wonderful talk, Dr. Spurgeon, Dr. Buchholz, thanks for that. Before we move on to the next talk, I do want to apologize that I forgot to mention that, of course, we also want to recognize today is September 11th, and we're remembering all of those who died on that horrible day that we all remember. If anybody needs to take a moment, please feel free to do so. But we want to acknowledge that we are remembering all of those Americans that died on September 11th. Our next talk is by Dr. David Hoganson. Dr. Hoganson is an assistant professor in the Department of Cardiac Surgery at Boston Children's Hospital, and we'll be discussing surgical management among children with heterotaxy.
My name is David Hoganson. I'm one of the pediatric cardiac surgeons here at Boston Children's Hospital. It's my pleasure to participate in this conference. I'm going to share with you some of our efforts in using 3D modeling and flow simulation for preoperative planning in patients with heterotaxy and complex congenital heart disease. Just some disclosures about some gift-in-kind software that we use from Dassault Systems and other software providers, and certainly a lot of what we'll talk about is off-label use. It's going to start with a patient. They sort of highlight some of the challenges that we have in patients with heterotaxy and congenital heart disease, as well as some of the ways we're using some of these advanced technologies to help understand and plan the right thing to do in these patients. So this is a patient who is a 4-year-old with heterotaxy, right-sided polysplenia, who has hypoplastic left heart syndrome with mitral stenosis and aortic atresia, and also has systemic venous abnormalities of an interrupted inferior vena cava with azygous continuation. And this patient underwent initially a stage 1 operation as a neonate, and then as an infant, he underwent a Glenn operation with anastomosis of the superior vena cava to the pulmonary arteries, and we left the azygous vein draining into the right atrium because he was a little bit young and the pulmonary arteries were a little bit small for Kawashima. And then as a 4-year-old presented for Fontan, but given the anatomy and particularly the systemic venous abnormalities, was at high risk for hepatic venous flow maldistribution to the lungs. And you can see here on the right, the 3D model that was created from the MRI that highlights some of the features of his anatomy. And this is looking at this 3D model with just the pulmonary arteries and the right atrium shown. And you can see here on the left side of the screen, the Glenn connection to the pulmonary arteries viewed from the front. And here, this is the right atrium added to that image. And you can see the relationship between the right atrium and the pulmonary arteries. And then here on the right, you can see the azygous vein that courses over that right pulmonary artery and connects to the right atrium. And you can see the relationships here and the complexities of what we need to consider as we think about how to do a Fontan completion in this child. And so the question then was, what Fontan operation gives adequate balance of blood flow to the lungs as well as low energy loss? And so certainly the first or standard consideration would be a lateral tunnel or extracardiac Fontan that incorporates the hepatic veins up into the pulmonary arteries. And also certainly we need to connect that azygous vein to the pulmonary arteries also. So that was one consideration. But then another question was something like an hepatoazygous shunt, where we bring the hepatic veins directly back to the azygous vein and then incorporate the azygous vein into the pulmonary arteries. Would that be a better option for this child, building on some of the experiences of other patients with interrupted inferior vena cava that we treated here at our center? And so really the goal is to achieve both low energy loss and then balance of hepatic venous return to both lungs to avoid pulmonary arterial venous malformations, which can occur in these patients, particularly patients with interrupted inferior vena cava, where all the blood flow from the liver can be directed towards one lung, and in the other lung, this pulmonary AV is confirmed. So certainly this is a principal goal to avoid in these patients. I'm going to share with you some of the workflows that we have utilized with these 3D models and the sort of process we go about in making them. So this is where the 3D models, they start from a CT scan or an MRI, and then from that we undergo a process called segmentation, which is a semi-manual process. We have a team of engineers that create these models for us, and then we have a digital 3D model of the patient's hearts. We used to 3D print these. We no longer do. We haven't for many years. We use them as sort of an all digital workflow. From the digital model, we can use them for preoperative planning and intraoperative guidance. We can also use them as a substrate for virtual surgery and planning different quantitative reconstructions like patch reconstructions. And then we can also use them to study the flow inside the heart with different surgical options, and then try to make the best decisions based upon that information. So this highlights a different patient with heterotaxy. This is a patient with dextrocardia and bilateral superior vena cava, and just highlight some of the different ways we can look at the anatomy with these 3D models. This patient has a left dominant AV canal, left IVC, and almost right upper pulmonary veins, another pulmonary venous confluence, and had stent in his right ventricular outflow tract. And so you can see how these 3D models really give us a unique perspective on the anatomy and the different relationships between the anatomical features. And they've really become a mainstay for how we plan and carry out these complex reconstructions in heterotoxic patients. We use the 3D models both before surgery as well as an intraoperative guidance tool, and we've reprogrammed several Nintendo switch controllers, and we're able to manipulate the model from the field and the screen in front of us and achieve any combination of anatomical features and views either inside or outside the heart to help guide us as we do these operations. We also use the models as part of an intraoperative conduction mapping program that's spearheaded by one of our other surgeons, Eric Fines, and two cardiologists that have really allowed us to use an EP conductance mapping catheter in the operating room in these patients, particularly patients undergoing biventricular repairs where VSD closure or a baffle could put the conduction system at risk. And not only are we able to identify the connection system in these patients, but we use the 3D models as a way to really annotate for each individual patient where the conduction system is found. And that's been extremely useful. And so in addition to the 3D models to represent the anatomy and be able to study it in a very intricate and quantitative way, we also use the 3D models as the substrate to plan reconstructions. And shown here is sort of the steps that we do that, where we take the 3D model of the patient's own anatomy and then design reconstructions such as a patch inside the heart or in one of the blood vessels. And this takes into account both the geometry and then some of the mechanical properties of either the patch material and the cardiac structures. And then often these patches are curved, and so there's a mathematical algorithm to create sort of the flat patch equivalent, because most of our patch materials start as flat materials. And then we're able to translate that patch design into the operating room with a laser system that shines the patch design down on the patch, so we can trace it out, cut it out with scissors, and then use it during the reconstruction. We also do virtual surgery for Fontan completions or Fontan revision operations, as you saw in the single ventricle heterotaxy patient we discussed a bit ago. And this highlights a patient with a complex ventricular septal defect that similar to what we often see in heterotaxy patients. And in this particular patient, there was a large membranous VSD with a corner ventricular extension. And this included some narrowing of the path to the aorta. And this represented a challenge to decide exactly how to both go about shaping the VSD patch as well as removing some of that obstructing tissue below the aortic valve. And in this patient, we were able to design the 3D patch for this patient. Also, with virtual surgery, remove some of that tissue below the aortic valve and plan exactly how we would do that. And we're able to come up with a 3-dimensional patch shape for this patient. And this just highlights a couple different views of this VSD patch, and certainly the both the curvature and the shape of the patch. You can see it's not planar by any by any means, and you can appreciate the challenge of shaping this just the right way in the operating room. And so doing this beforehand can be super helpful, particularly noting the annotations of how the patch will need to be aligned with the different structures, the tricuspid valve and aortic valve, for example. And then we're able to create the flat patch equivalent with this 3D experience tool that's used in aerospace engineering, and not only get the dimensions of that flattened patch equivalent, but also annotate on that patch exactly how it's going to line up with the different anatomical features. And then we're able to use a laser projection system that we borrowed from the aerospace industry that is very common there, and project the patch design down on the patch material. And we've studied this carefully in different patch materials and shown there's less than 2% error between the patch design and the patch size after it's traced out over the laser pattern and then cut out with scissors. So this is a really nice way to translate that carefully designed patch onto the sterile patch material in the operating room. And then another way we're using this 3D model workflows is to simulate the flow through the heart, particularly in single ventricle patients. And so from this, we again start with the patient's own 3D model, and then we model different surgical options, often Fontan revisions or completions. And then we take the patient's own physiologic data from their MRI and cath data. And then we do a computer simulation of how we expect the flow to go through the different anatomies using the patient's own physiology. So this isn't simulating the flow in general. This is simulating what we actually expect for this individual patient, including utilizing their expected resistance of blood flow through the lungs for these single ventricle patients. And then we're able to analyze the flow simulation results, and from that understand what's the best option for low energy loss and good distribution of blood flow to both lungs. And then we use that selected plan for intraoperative guidance when we do these surgeries. And so one important thing that we've learned is that usually for these small children, the information from the cath and the MRI are obtained when the patients are under anesthesia. But it's really important to model the circulation under several different physiologic conditions to really have a robust analysis and then really understand how the flow is going to be in real life. And of course, nobody lives under anesthesia. And so we really want the Fontan circulation to work well under normal resting physiology after the child eats and when the child exercises. So we're able to plan that out and test that physiology under different conditions to really know how robust of a surgical solution are we proposing. And so if we can jump back to that patient we first talked about, this 4-year-old with heterotaxy and right-sided polysplenia, hypoplastic left heart syndrome, who underwent the stage 1 and then the Glenn. Now we're trying to understand what is the best option for Fontan in this patient. And this demonstrates the hepatic flow distribution for lateral tunnel or an extracardiac kind of a connection where the hepatic veins are connected directly up underneath the pulmonary arteries, and then that azygous vein is also connected to the right pulmonary artery. And what this shows is under normal resting conditions, the hepatic venous flow would be really skewed towards the right lung. And so it looks here like we expect 90% of the hepatic venous flow to go to the right lung and only 10% to the left lung under normal resting conditions. After eating, it's a little bit better with 20% of the blood flow going to the left lung because the overall liver flow after you eat goes up substantially. But with exercise, we predict 100% of the hepatic venous return to go to the right lung. Nobody knows the minimal amount of hepatic flow to one lung that's necessary to prevent ABMs, but we typically shoot for at least 20% or more to one lung, and ideally it would be much closer to well balanced, particularly for a patient who's not a Fontan revision but undergoing their initial Fontan operation. So we knew we needed to make some changes and look at other options in this patient. And so then we asked the question of what about a hepatoazygous shunt, where the hepatic veins are connected directly back to the azygous vein? often in these patients with interrupted inferior vena cava, that's a good option. Just given the individual features of this patient anatomy and how we expected, we would incorporate that azygos vein into the pulmonary arteries. Also, it gave us a picture of what that might look like. And it definitely was better with 81% of the flow from the hepatic veins going to the right lung and 19% to the left lung under normal resting conditions. Again, a little bit better with postprandial and exercise, but this was still, riding a sort of a little bit of a narrow margin on being sufficient for this patient. And so we want to take it one step further and say, could we change the flow a little bit to make it even a little bit better? And as you can see here, it's really sort of a situation where the blood that comes down from the superior vena cava mostly goes to the right lung, and the blood flow that comes up from the azygos, or excuse me, mostly the left lung, the blood that comes up from the azygos goes mostly to the right lung. And so we wanted to see if we could improve the mixing where the superior vena cava and the azygos came together. And so what we did is we designed a patch to add to that area that would allow that those streams to cross and have better mixing of that hepatic venous flow. We were able to dimension that patch, get the flat patch equivalent, and be ready to use that in the operating room that did improve the expected flow conditions. And so when we looked at this again with the flow simulation, now we had a substantial improvement. And so if you look at normal resting conditions, now 63% of hepatic venous flow went to the right lung and 37% to the left lung. So this is much better. And this was the option we chose to pursue in this patient. So, and then for all these patients who we do this flow simulation before surgery, we also do a repeat MRI after surgery, so we can really understand what the outcome was, and if our analysis really well predicted what would be the outcome. So if you look at the upper chart for this patient, the hepatic flow distribution predicted was 63 to the right lung and 37% to the left. Post-op, when we reran the analysis with the post-op anatomy, we got 70% to the right and 30% to the left, so pretty close. In the total flow distribution to the lungs, we predicted 57 and 43, and the MRI gave us 51 and 49. So again, quite close to our predictions and a really nice outcome for this complex patient who's clinically done very well. And then we've done this in many other patients, and this just gives you a sense for some of the other challenges we see in these complex single ventricle patients with heterotaxy. This patient also had an interrupted IVC and azygos continuation, but with bilateral superior vena cava, which is a really challenging situation and what to do. And so what was initially proposed is we would do a standard Fontan in this patient, but as you can see in the pictures B and C, this resulted in all or nearly all the hepatic venous blood going to the left lung. And so in this patient, we did do a hepatoazygos shunt, and that resulted in a pretty nice distribution of 52 and 48% shown here in F. And the child underwent that operation and had a really nice outcome. And so this has been used in many of these complex patients to really predict the best approach as shown here. And we've worked very hard to validate the computational fluid dynamics flow simulations in these Fontan patients, and we get MRI follow-up in all these patients. And this is just a group of 4 patients with interrupted IVC and azygos continuation, which we often see in these heterotaxy patients. And the overall flow balance in these 4 patients, the CFT model predicted 51 to the right and 49 to the left, plus or minus 5%. And the post-op MRI was very similar at 49% to the right, plus or minus 8%. So our really hard work to try to define the patient's individual physiology with cath and MRI data has paid off well with really nice similarities between what we're predicting by the flow simulation and what we're getting by MRI after the surgery. Also want to share with you another 3D modeling effort we've done in these patients which is trying to model their AV valves. And certainly these patients, many heterotaxy patients have a complete AV canal anatomy or other features of their AV valves, which make them challenging to both understand and repair. And so similar to the 3D models you've seen earlier, we're also now able to model the AV valves, the canal type AV valve or a regular AV valve, and that's given us tremendous information about the leaflet structure, the annular structure, and the subvalvular structure. And you can see here, we can get sort of any view of these valves using this 3D viewer. That is a web-based viewer, and we're able to make measurements of the valves, such as the portal lengths, and understand the relationships between the leaflets, and then really use all these dimensions to start to plan what we're going to do in the operating room to best repair these valves. We have a big team of engineers and that make the valves, or excuse me, make the 3D models, including Rena, who's a cardiologist who focuses on valve modeling. And this team of engineers both creates the 3D models and then does the engineering work to plan patches and perform flow simulation and validate these workflows in the lab prior to clinical use. Thank you again for the opportunity to present at this conference. This is my email. I'll be happy to chat with anybody about these type of.
Extremely fascinating work, really brilliant stuff. Thank you, Dr. Hoganson. I'm sure my son will be thrilled to know that one day he might be able to use his Nintendo skills to be a cardiac surgeon at the Boston Children's Hospital. We will be starting the next talk at 11:05. We're kind of cutting into the break now. At 11:05, we'll start the next talk. Just a reminder that people are more than welcome to ask questions into the chat. We will compile all those questions and try to get them all answered during the question and answer period at the end of all the discussions this morning. The next discussant will be Dr. Andrea Garrett, who is a pediatric pulmonologist at the University of Virginia. That talk will start precisely at 11:05 Eastern Time.
Dr. Andrea Garrett, and I'm here to talk about respiratory disease and ciliary dysfunction in patients with heterotaxy. I am a pediatric pulmonologist and the primary ciliary dyskinesia center director at the University of Virginia. Thanks for having me. So in our talk today, we'll cover some big headlines. We don't have much time together, so I'll try to get through all the content and hopefully not rush too fast, and then have questions when we all join back together in the end. So we know that patients with heterotaxy have lower lung function. Here's our first headline. All right, so what is lung function? When I say lung function, what do I mean by that? So in pulmonology, we review pulmonary function tests. This allows us to have some degree of objective measurement for patients' lung disease, and we use it to evaluate symptoms and to evaluate response to therapy. In the following slides, I'm referring to this type of pulmonary function testing. So this is a study from 2019 that looked specifically at lung function in patients with congenital heart disease. They found that about 1/5 of children with congenital heart disease will have some impaired lung function, and that those with impaired lung function had some predictor of mortality associated with that. And then that specifically a restrictive pattern correlates with problems with exercise capacity as well as quality of life. They looked over different types of congenital heart disease, and logically, patients with a more complex congenital heart disease, such as heterotaxy, had significantly lower lung function as compared to other groups. This is another study from 2017 that compared patients that are healthy to those with primary ciliary dyskinesia to those with Fontans. And then they separated the Fontan group into those with isomerism and those without isomerism, using isomerism as a marker of heterotaxy. So the groups here are relatively small in their total number, so take it all with a grain of salt. But similarly to the last group, the patients with Fontan physiology, so congenital heart disease, had significantly lower lung function, specifically restriction. Those with PCD had a little bit more obstruction as compared to the other groups, certainly as compared to the healthy groups. And interestingly, there wasn't a huge difference between the Fontans with and without isomerism, but those with isomerism actually had slightly better lung function. We also know that patients with heterotaxy have more post-operative respiratory complications as compared to those with other types of congenital heart disease. So this study compared all patients with congenital heart disease and took patients with heterotaxy compared to other types of congenital heart disease. And then using a standard risk adjustment, matched similar patients to their severity. So we're equally severe types of congenital heart disease, but some with and some without heterotaxy, and compared outcomes in those two groups. They found that those with heterotaxy as compared to non-heterotaxy congenital heart disease had more respiratory complications like needing mechanical ventilation, tracheostomy placement, and ECMO, as well as having increased mortality and longer lengths of stay in the hospital compared to those without heterotaxy in congenital heart disease. Which brings us to the why. Why do we think our heterotaxy patients might be having these pulmonary complications and issues with lung function? So we know that cilia look to play a role in the development of congenital heart disease. And the beginning work of that model came from Cecilia Lowe's lab, and she will be speaking with you guys tomorrow and will be able to speak to this much better than I can. But when I was a fellow in training, I had the pleasure of being in her lab. And at that time, this article from Nature was published about the role of ciliary genes in the development of congenital heart disease in a mouse mutagenesis model, which certainly got me thinking as a trainee a lot more about this. So why are we talking about cilia, and where is cilia located in the body? So cilia are located anywhere in your respiratory epithelium as well as in your embryonic node. The image on the left is ciliary motility in an airway, and that's normal motion. You can see kind of sweeping motion, sweeping mucus out of the airway. The other image is in the embryonic node. In the embryonic node, the structure of the cilia is slightly different, and because of that, the cilia move differently. So compared to that wave motion, they kind of move in a rotary motion, and that determines flow within the embryonic node, which changes the dynamics between left and right. So the thought is that this determines your left and right access in the body. Which brings us to a slight bit of a tangent about primary ciliary dyskinesia. So primary ciliary dyskinesia, as described, is a disease where cilia do not have functional movement, have dysfunctional movement. And because of that, we see both pulmonary respiratory symptoms, as well as differences with things like organ situs arrangement and heterotaxy. So this will all come back around to heterotaxy. So we talk about organ laterality. We're just talking about the embryonic node and flow within that node. In an absence of flow, which would occur in patients with that dysfunctional motility or absence of motility, so there's no flow in the embryonic node, your organ situs is going to be random. So in patients with primary ciliary dyskinesia, they estimate a little under half to have situs solidus or normal organ arrangement, a little under half to have situs inversus totalis, so mirror image organ arrangement, and about 12%, and this number can vary across studies, to have situs ambiguous, meaning random arrangement of your organs on the left and right side of your body. And it's in this category of situs ambiguous that we'll see patients with heterotaxy. So how do we diagnose PCD? First, you have to have the phenotypic feature. So do you have signs and symptoms that suggest you have PCD? And if so, we move on to diagnostic testing. There's no single test that captures all PCD patients to have a diagnosis. So in the testing protocols in general, the more number of tests you have that are positive, the more likely it is that you have primary ciliary dyskinesia. And some appear to be more definitive than others. I talked a little bit about the signs and symptoms. So patients with PCD generally have neonatal respiratory distress. About 80% have neonatal respiratory distress. Nearly all of them will have a daily productive cough. Most of them will have chronic sinusitis, chronic rhinorrhea, recurrent otitis media, and then later develop some bronchiectasis. There's also different types of findings we can find in other parts of the body, like issues with fertility and hydrocephalus. When we're trying to decide who to test for PCD, the recommendation is that patients have at least 2 of the 4 of the following typical features of PCD, those being that respiratory distress, year-round daily wet cough starting before 6 months of age, year-round daily nasal congestion starting before 6 months of age, or an organ laterality defect. So in our patients with heterotaxy, you can imagine they would meet the criteria for organ laterality defects, and many of them have neonatal respiratory distress. The hard part is trying to determine whether that distress is associated with a cardiac disease or whether it's respiratory disease. But certainly once we start seeing the sinus and lung symptoms, we get much more worried. How we do the diagnostic testing can be by genetics, by nasal nitric oxide, or by testing ciliary ultrastructure by electron microscopy. Less commonly in the United States, more commonly in Europe, they'll do ciliary motion and waveform analysis by high-speed video microscopy. And in some labs, they'll do immunofluorescent staining. Nasal nitric oxide testing at this point is mostly available in specialty centers like PCD centers. To do that test, you have to be able to follow directions, at least to do the most typical technique that we do in patients over the age of 5. So the patient has to blow against a resistor, and they have this little tube that goes into their nose attached to this foam piece. And that tube very slowly draws air out of the nasal cavity and tests the amount of nitric oxide in it. And in patients with primary ciliary dyskinesia, that number is lower compared to the general population. All right, so now back to our heterotaxy patients. So what do we know specifically about ciliary dysfunction in patients with heterotaxy? So this was a group that looked at ciliary motility, nasal nitric oxide levels, and respiratory symptoms in patients with congenital heart disease with heterotaxy. So they looked at a large cohort of these heterotaxy patients and studied these sort of typical PCD type findings, and found that many patients with heterotaxy had abnormal ciliary motion on high-speed video microscopy. And then they also did those nasal nitric oxide levels. So they found that in the patients with heterotaxy that also had abnormal motion, those patients had lower nasal nitric oxide levels, more respiratory symptoms, and more complications in the post-op period. They had more beta agonist use, so they received more albuterol, they had more trachs placed. And so this is compared to heterotaxy patients that had normal motion. So this entire group was just heterotaxy patients, but those that had abnormal motion also seemed to have more respiratory findings and more findings that would suggest they had a primary ciliary dyskinesia type picture. So this is work that I got to do as a fellow in Dr. Lowe's lab. We looked at ciliary dysfunction in both heterotaxy and non-heterotaxy congenital heart disease. And then similar to the last study, we looked at those two groups, heterotaxy and non-heterotaxy, and divided them up by whether or not they had abnormal or normal ciliary motility, their nasal nitric oxide levels, and also did a questionnaire for respiratory symptoms. In our group, you can see in these diagrams that in general, the heterotaxy group had more abnormal findings. So in the corners there, you can see the heterotaxy group, about 20% had both normal motion and a normal nasal nitric oxide level. And in the non-heterotaxy group, slightly more of them had normal motion and normal nasal nitric oxide level. And in the heterotaxy group, there was a good percentage of patients, so 33% of patients had both abnormal motion and an abnormal nasal nitric oxide level. We then did further data analysis, also looking at symptoms, and interestingly found that heterotaxy was not an independent risk factor for the increased number of symptoms. The thing that was associated with your symptoms was the abnormal motility and a lower nasal nitric oxide level. But as we mentioned, in general, more of those patients happen to have heterotaxy. So this brings up a concept that we in the heterotaxy and PCD community have been looking at, this idea of heterotaxy related respiratory ciliary dysfunction. So we're seeing a lot of heterotaxy patients that don't necessarily have as robust symptoms as our PCD patients, but they have many of the similar symptoms. Some of them are getting bronchiectasis, many of them are getting recurrent sinopulmonary infections, and some of them are having ciliary dysmotility and lower nasal nitric oxide levels. All right, so moving on past this question of cilia, we also know that our patients with heterotaxy get other types of lung disease for many different reasons. And what are those lung diseases? So these are conditions associated with heterotaxy that can lead to other pulmonary problems. So we know a lot of our heterotaxy patients have a suppressed immune system that can lead to recurrent respiratory infections. And those respiratory infections can lead to things like bronchiectasis and other complications. There's a lot of ways those heterotaxy patients can have immunosuppression, including things like problems with their spleen, having a heart transplant that is suppressing their immune system with medications, having immunoglobulin depletion if they have protein-losing enteropathy after a Fontan, and a myriad of other reasons. If these patients are getting respiratory infections, then they should have a pulmonologist involved. Many of our patients with complex congenital heart disease are born preterm, and we know that preterm birth in and of itself can be associated with lung disease. Many of them have Fontan physiology, single ventricle physiology, and we know that patients with Fontans can have plastic bronchitis, which can be quite frightening. And in general, they seem to have more sleep issues. And then lastly, we know that kids with congenital heart disease, including heterotaxy, can have associated pulmonary vasculopathies that need to be addressed separately with the team. Sometimes what we do to treat our patients with surgery can also result in other complications. So post-surgical lung disease is quite common. In the process of the surgery, there can be nerve damage that causes vocal cord motility issues. And in patients that aren't able to close their vocal cords, they're more likely to aspirate, which obviously can cause long-term pneumonitis. They can have injury to the nerves of the diaphragm that cause the diaphragm not to move well, either on one side or on both sides. That can require positive pressure due to the respiratory insufficiency. The ventilator itself can cause some degree of lung injury. These patients can have issues with chest wall compliance and weakness from the surgeries that they've had. Pulmonary hemorrhage is a complication, and many patients that we see will have pleural effusions as well. So, you know, the heart and the lungs are neighbors, and oftentimes if we're dealing with one, we're dealing with the other. Okay, now what do we do? So who should be on the team? What should we be testing for? How should we be caring for these patients? Is something that we're trying to work on as a subspecialty group. So this would be the team that we would recommend for patients that have pulmonary complications of their heterotaxy. So the assumption here is that you already have your cardiologist on board and your cardiothoracic surgeon, but what about the pulmonary complications? So having access to a good pulmonologist in our pediatric patients, we'd be obviously talking about pediatric pulmonology, a good respiratory therapy team, genetics to work through the complex genetic diagnosis of reasons for primary ciliary dyskinesia or congenital heart disease, pediatric radiology to look at the studies, pediatric otolaryngology to look at the complications of PCD in particular, speech language pathology to help with assessments of aspiration, dietitians to make sure our patients are growing, and social workers to make sure that we're supporting not just our patients, but the whole family in the complex care of our patients. The diagnosis of lung disease oftentimes will depend on how the patient is presenting. So we would recommend that pulmonology be consulted in all patients with heterotaxy. I think the big question here is, you know, at what point should that be? Does it need to be at birth? Chances are at birth, we're not going to be able to see a lot of the symptoms that might point us in a certain direction. But involving pulmonology in the perioperative period, involving pulmonology when the child gets old enough to do PFTs, make sure these patients are having baseline chest x-rays. This would be sort of the baseline care that we would recommend for all heterotaxy patients. Studies to consider based on symptoms are going to be specifically tailored to the child in front of you or the patient in front of you. So if the patient has signs and symptoms consistent with primary ciliary dyskinesia, right, those pulmonary symptoms we were talking about, then we would recommend testing. There are specific guidelines for testing, but ideally get them to a center that has nasal nitric oxide testing, involve your genetics team with looking at genetic testing. And if your local hospital can run electron microscopy, that's great. There's other places you can send it out to also assess good ciliary epithelial biopsies. We would recommend chest ultrasound afterwards if these patients are having a lot of issues clearing their secretions or ventilating, or if the diaphragms are looking different on x-ray. Obviously, we need to look at their diaphragm motion. A swallow study to look for pulmonary aspiration if we're having issues with chronic cough. A chest CT in general can be very helpful whenever our patients are having chronic wet cough. Maybe, you know, they don't have PCD, but there's other ways to be developing bronchiectasis that would really drastically change the treatment of these patients and their follow-up. Those types of things might be things like respiratory cultures, right? If we find bronchiectasis, if the patient has an immunodeficiency or heterotaxy-related respiratory ciliary dysfunction, we should be looking at cultures to make sure we're screening for problematic bacteria that could be treated before causing more morbidity. Flexible bronchoscopy should be considered in patients if you have concern about abnormal anatomy, injury to the airway, compression to the airway after some of these surgeries we certainly see often. And then watching for sleep symptoms. This is especially true whenever we have patients with baseline low oxygen saturations, and we need to be worried about pulmonary hypertension, but a lot of these patients will have sleep apnea. So taking a look out for those things and ordering a sleep study whenever it's appropriate. Management is going to depend on what you find. So if you find PCD, there's a consensus statement for therapy. We would recommend you get them over to a PCD center. Airway clearance strategies for these patients whenever they're going into the operating room or to avoid complications after surgery are important. The exact modality you might use or the medications would be up to the subspecialty team based on an individual patient. And then again, we talked about respiratory cultures. All of these patients should be seeing their primary care provider, make sure they're getting their vaccinations and their frequent checkups. How often you're going to need to be seen by the pulmonologist is going to depend on the underlying condition. But we would want to standardly follow any patients that are having chronic symptoms. And in general, just pick up the phone, call your pulmonologist. Call the subspecialty center or the specialty center for PCD if you have a patient at your center that might not have a PCD center per se. We're always happy to answer a question. Just send us an email. And that is all I have for you. Thank you for your time, and hopefully I will get to talk to you all in just a minute.
Wonderful, Dr. Garrett. Thank you very much for that really excellent overview of the pulmonary complications of heterotaxy. We are starting to learn that heterotaxy is a complex condition involving not only the heart, but multiple other organ systems in the body, including the gastrointestinal system. Dr. Michaela Tracy is a clinical instructor in the Department of Pediatrics and the Division of Gastroenterology, Hepatology, and Nutrition at the Boston Children's Hospital.
Good morning. My name is Michaela Tracy. I'm a pediatric gastroenterologist at Boston Children's Hospital, and I'm here this morning to talk to you about gastroenterology considerations in heterotaxy syndrome. I have nothing to disclose. Some brief objectives are to talk about some well-known structural GI complications of heterotaxy with a lot of focus on intestinal rotation anomalies. We'll talk briefly about biliary atresia, and then one slide on sort of what is not known about GI complications in heterotaxy. So we'll start by talking about some structural GI complications of heterotaxy. And this first group are actually anatomic abnormalities that are part of the diagnostic criteria for heterotaxy syndrome. The first group is abdominal situs abnormalities, which we can look over here in our picture. On the left side here, we have sort of normal anatomy. We have our left-sided heart with stomach and spleen also on the left, and our liver tucked up under on the right. Comparatively, if you go all the way over here, the opposite of that would be complete abdominal situs inversus, where we have our liver over on the left now, and our spleen and our stomach are on the right. In the middle of that spectrum, though, are what is known as midline or transverse liver, where you can see that the liver, instead of being just on one side, actually crosses the midline. There are two forms of that. There's right isomerism, which is more likely to be associated with asplenia, and then there is left isomerism, which is more likely to be associated with polysplenia. Other sort of anatomic anomalies that comprise diagnostic criteria include intestinal rotation anomalies that we'll talk a lot about, and absent gallbladder. Outside of those diagnostic criteria, there are many other GI structural abnormalities that are well documented in heterotaxy patients. The first two, annular pancreas and agenesis of the dorsal pancreas, have to do with embryology of how our GI tract develops when we're a fetus. Here you can see you have your intestine, which will later become your duodenum, the first part of your small intestine. And when your pancreas is forming, you have two different buds. You have a ventral bud over here and a dorsal bud over here. During normal embryology and development, your intestine rotates counterclockwise so that this ventral bud swings over and joins up with the dorsal bud over here, which ultimately becomes one singular full functioning pancreas. You can imagine if this swings clockwise instead of counterclockwise, this little dorsal bud or ventral bud, ends up sort of wrapping around the front of the duodenum, which we call an annular pancreas. If it's too tight, it can cause compression or obstruction, which is a problem. Agenesis of the dorsal pancreas essentially just means this large dorsal bud, which is the large majority of what becomes the mature pancreas, never develops. And so all somebody would have would be this tiny ventral bud, which may lead to problems with issues of the pancreas down the line. Other common anatomic abnormalities that are well documented in literature for heterotaxy patients include duodenal atresia, where part of the duodenum, which is the first part of the small intestine, does not develop. So it's atretic. You can have a pre-duodenal portal vein, which essentially means you have this portal vein, which is a large vein that usually sits behind your duodenum. But again, if it sits on top, similar to sort of an annular pancreas, it can cause compression and obstruction. Microgastria, which is a fancy word for small stomach, which you can imagine can be a problem in an infant if their stomach is too small. They can't take in enough food to grow. They might have problems with vomiting or with bad reflux. And then these two at the bottom here, in italics, anal atresia and tracheoesophageal fistula are sort of case reports of heterotaxy patients having these. Anal atresia meaning there's no exit from the GI tract through your anus. And tracheoesophageal fistula, meaning there's an abnormal connection between your trachea and your esophagus. Of course, the large lion's share of issues that come up have to do with intestinal rotation anomalies. And these next few slides are largely adapted from one of my colleagues, our surgeon, Dr. Ben Zendejas. So intestinal rotation anomalies are when there's an incomplete or non-rotation of the intestinal contents around the SMA, which is your superior mesenteric artery, during embryologic development. It's somewhat rare. It's about 4 per every 10,000 infants, more likely to be in males than females by about a 2-to-1 ratio, and most commonly identified in infants, so those less than 1 year of age. Importantly, it can be associated with other anomalies. And you'll see here, obviously, that we're talking about today, a large portion of heterotaxy patients are thought to have intestinal rotation anomalies, somewhere between 40 and 90%. I think before we talk more about this, it's really important to talk about what normal intestinal rotation in utero is like. So again, taking us back to some embryology, normally beginning around gestational week 5, the midgut, which eventually turns into your mainly your small intestine, undergoes a sequence of growth, elongation, and rotation, which yields what we end up having a normal anatomy positioning inside of our abdomen. Essentially, what happens is you have a bunch of the intestines that actually come outside, meaning herniate or leave the fetus outside of the fetus, so that they can grow with enough space. Ultimately, when they come back into the abdomen, these are supposed to do a few important turns. The first turn to think about is this proximal duodenal jejunal loop, and that just is the fancy words for the first part of your small intestine, is meant to rotate 270 degrees posterior and to the left. And what that ends up being is this beautiful C-sweep, we call it here, where this part of your small intestine crosses your midline. Oppositely, your cecocolic, which is basically your cecum, the first part of your large intestine and the rest of your large intestine, are meant to move anterior and to the right so that they end up, your cecum ends up down here in the right lower quadrant. What's most important is that at the end of all of this, you have this long structure called the ligament of Treitz that ends up tacking your small intestine up here in your left upper quadrant, and then your large intestine down in the right lower quadrant. And this large ligament is important because your mesentery sort of fans out from there and has a broad width in a normal person anatomy. This is a complex process, as you can imagine, so disruption at any point during that process can lead to malrotation. But every malrotation can be different. You know, there's a spectrum of things that can go wrong, which leads to a spectrum of different options. The most common intestinal malrotation refers to when the duodenal jejunal limb, which is this right here, doesn't rotate at all. It's non-rotated. So instead of having that nice C-sweep we saw before, it just goes straight down. And then you have this cecocolic, which is again the large intestine, partially rotates, but it doesn't actually come all the way down to the right lower quadrant. So instead of being down here, it's up in your mid-abdomen. And then instead of having that nice long ligament of Treitz that we saw, that nice long diagonal, you have these what are called Ladd's bands, which are essentially like strong tissue bands that attach the cecum to your abdominal wall. You can see here that it crosses over the duodenum, which can be a problem, causing obstruction, and it can also lead to something called volvulus. So the two sort of main considerations when thinking about intestinal malrotation are those two things. One, the first thing is that instead of having this nice long band ligament of Treitz where you can see the mesentery is nice and fanned out, you have a very narrow mesenteric base, which makes it very easy for this intestine to twist among itself, and that is called volvulus, which we see depicted here. The other problem to think about is that you have Ladd's bands crossing the duodenum, like we saw in the prior picture, that can lead to obstruction. So what is volvulus? Volvulus is the fancy term for intestines twisting around itself and that mesentery that supports it, which causes a bowel obstruction. The reason that this is such a hot topic is that it can lead to death or necrosis of the bowel, and in extreme cases can lead to sepsis and death. The symptoms are abdominal distension, meaning like bloating, big belly, pain, vomiting, which may or may not be bilious. Bilious emesis is shown down here in this sort of bright fluorescent green. Kids can show up as constipated and have bloody stools. The workup, super important if there's any suspicion for this, that an upper GI series should be done, which is depicted here when a patient swallows dye and we watch it. Here you can see that it fills the stomach, and then you can see this corkscrew. You can imagine that the intestines are twisted on themselves here, and then you see no further dye because it's obstructed or blocked. This then would lead to a surgical consult for emergent intervention. The intervention is called a Ladd's procedure, where the surgeons open up the belly, take a look at the bowel, they untwist it, and then hopefully there's no necrotic bowel, and they sort of tack the bowel up inside the abdomen where it's meant to stay. Just to round out our intestinal rotation anomalies, there's something called intestinal non-rotation, Or essentially after those, the midgut comes out of the abdomen and grows. When it goes back into the abdomen, it actually doesn't rotate at all. So it's non-rotated, and you can see the small bowel just goes straight down instead of that swoop over here. And the large bowel is again sort of more in the mid abdomen rather than the right lower quadrant. This though has a much lower risk of volvulus, once again, because instead of having that narrow mesenteric base, the mesentery here you can see is more fanned out like a normal looking mesentery. So why is this, what is the hot topic about this? This, because we know it is so common in heterotaxy patients, there was a period of time where patients were prophylactically screened and then actually having LADS procedures, again, that corrective procedure done. And then there's been a lot of research into this, those are no longer the recommendations. And here's some data as to why. So there've been a few systematic reviews done. This was looking at is screening for malrotation essentially in heterotaxy patients really necessary? This followed 414 patients who were managed expectantly, meaning they were not screened, they were just watching to see what happened to them. And of that 414, one singular patient went on to develop a symptom that was attributable to an intestinal rotation anomaly. On the other hand, there was a screening group where kids were screened just once they knew they had heterotaxy. Among that group, 53% ended up with a LADS procedure, and the overall complication rate for that was 17%, which is quite high. Additionally, the 30-day mortality rate for those kids was between 2.6 and 4.6%, very high, and all of the deaths were attributed to cardiac respiratory failure. So this review sort of suggested that asymptomatic patients are at very low risk of developing complications from an intestinal rotation problem, and that surgical intervention actually carries significant complication rates. Similarly, another systematic review about the next year was looking at observation versus prophylactic LADS procedure. And in this, there were 649 heterotaxy patients. 27% of them underwent a LADS procedure. However, of those, only 8 of them, or 1.2%, actually had a LADS procedure for volvulus. The rest were prophylactic. Again, the post-operative complication rates were high, 14% here. 10% had a small bowel obstruction, meaning they had to go back to the OR. Perioperative and overall mortality rates were quite high, 3% perioperative and 21% overall mortality rate. So again, showing that sort of high rates of complication for low risk of actually having problems. And then lastly, there's been looking into is fixing these, is undergoing a LADS procedure, putting these infants at higher risk for early shunt failure. And this followed two sort of groups of patients, 54 children who had heterotaxy syndrome and single ventricle physiology who had a LADS procedure. Again, of the 54, only 3 had symptoms, so the rest were prophylactic. 7% had to go back to the OR for a bowel obstruction, and almost 6% had in-hospital mortality. And then there was 21 children who had heterotaxy, single ventricle physiology, and a systemic pulmonary shunt who had a LADS procedure. And 20% of those had early shunt failure after their LADS, again, showing that this is like a high-risk procedure for this group. So the summary for this would be to say that malrotation is very common in heterotaxy, but symptomatic malrotation or volvulus is actually extremely rare. We think less than 5% of the time, and these studies even say around the 1% mark. These studies also showed that LADS procedure carries significant morbidity or mortality risk in this population, and so therefore prophylactic LADS procedure is not indicated, and screening asymptomatic patients is also not indicated. And so just round out this area to say sort of the clinical implications of the structural anomalies that we've talked about, including the pancreas problems, duodenum problems, the intestinal anomaly problems, is that some clinical applications, there actually may be none, right? We think up to 70 or even 90% of heterotaxy patients have malrotation and are asymptomatic. Volvulus, of course, as we talked about, is a known clinical complication. Obstruction, which we can see in the malrotation. We can also see it in things like duodenal atresia and our annular pancreas. Feeding intolerance is common, could really be a result of many of the anatomic anomalies. Atypical abdominal pain is an important thing for children and parents of kids with heterotaxy to have on their mind. This essentially means you can imagine if your appendix is in your mid-abdomen because you have malrotation and it's not in your right lower quadrant, that people may present with appendicitis having mid-abdomen pain instead of right lower quadrant pain. And so it's really important to have it on people's minds that perhaps pain would present differently than what sort of medical personnel are used to. And then there is some data, although it's a little bit murky, about increased risk of gallstones, pancreatitis, and diabetes mainly in the children who have pancreas issues related to their heterotaxy. And so now I'm going to touch briefly on biliary atresia. I'm very fortunate in that in my institution, I have a whole liver team who I can refer patients to. And so I've borrowed some of these slides from my colleague, Dr. Wehrman. Biliary atresia is a very rare liver disease that affects infants. It's about 1 in every 8 to 15,000 infants. The cause is unknown, but it leads to sort of progressive fibrosis or scarring of the bile ducts in the first few months after birth. Like I said, etiology unknown. We don't really know. Could it be environment, the viral trigger, or some immune dysregulation? There is a surgical treatment, although it is not a cure, called a Kasai procedure, which is a hepatoportoenterostomy, essentially meaning taking out all of these dead atritic biliary ducts and then attaching the intestine directly to the liver to allow bile to drain again. Unfortunately, despite this corrective surgery, about 40% of children who have biliary atresia will need a liver transplant before the age of 2. And actually, biliary atresia is now the leading indication of pediatric liver transplants in the United States. Early surgery is really important because it's been shown to improve transplant-free survival. But unfortunately, early diagnosis is very challenging due to sort of non-specific biomarkers, lack of signs, sort of clinical signs until very late in the disease, and then also delayed presentation to hepatology. Important to talk about this, there is an entity called biliary atresia splenic malformation syndrome. And that is that about 10 to 15% of patients who have biliary atresia have laterality defects, which would include malrotation, polysplenia, eardrum IBC. Unfortunately, these children with BASM, seem to present earlier to care, which you would think would be good because we talked about earlier is better, but have worse outcomes. Late diagnosis of biliary atresia affects long-term outcomes. Children who have a successful Kasai procedure when they're young are less likely to require liver transplant in infancy, like we talked about. And we think that the Kasai procedure is more likely to be successful the younger the infant is. For a long time, we have used 60 days, meaning the infant who has the corrective procedure before 60 days of life is more likely to have longer survival. And there's newer evidence saying that actually that number should probably be 30 days of life, so quite early on. And unfortunately, the average age at the time of Kasai in the US is more than 60 days. And this is just a picture showing that essentially, like we talked about, they take part of the small intestine and attach it directly to the liver to help bile flow out. Bile, if it stays in the liver, causes scarring, ultimately cirrhosis, and then causes liver failure and can cause death. So what to do about this? There has been a large study taken place in South Texas between 2015 and 2018, where every newborn was screened within the first 60 hours of life with a heel stick for both their total and direct bilirubin. If things were normal in the first 60 hours of life, they were not followed again. If they were abnormal, they had a repeat check at their 2-week well child check. And this is just a schematic of what happened. So there were 125,000 births and about 122,000 kids screened out immediately at the 60-hour of life mark, meaning that 99% of infants were negative on their first screen. Of the remaining, 1.1%, there were then almost 9% of infants who were positive at their second screen, meaning 119 patients. Of those, 7 patients end up having biliary atresia. Important to note, all patients with biliary atresia here had positive stage 1 and stage 2 results, which leads to, as you'll see, very high sensitivity, very high specificity, and very high negative predictive value, but unfortunately very low positive predictive value because you end up with 7 out of the 125,000. But we're thinking about cost-benefit analysis considering how progressive and high mortality this disease has. And so biliary atresia, just our quick conclusion on that, is that any abnormal direct bilirubin at birth or shortly after birth is abnormal and needs to be repeated and evaluated, especially in infants with heterotaxy. So that leads me to sort of our last point, which is thinking about what is not known about GI complications of heterotaxy. You've heard during this about many different anatomic things that can go awry, but we haven't talked about at all how the GI tract actually functions. Which the motility or dysmotility of the GI tract, meaning how does it move through the lung, how does it absorb? We know that there are problems with motility and dysmotility. You end up with feeding intolerance, constipation, abdominal pain, bloating, which many heterotaxy patients experience, at least in their infancy. But we don't know at all about how the GI tract actually works in those patients. If there's a problem outside of a structural issue or related to a structural issue. We don't know anything about patient-reported GI outcomes. Are heterotaxy patients out there having belly pain, constipation? We don't know. And what are sort of just the rates and morbidity of the GI complications that this population sees? So in conclusion, we say that structural anomalies of the GI tract are very common in heterotaxy, and some are even diagnostic criteria. Intestinal rotational issues are common, but are unlikely to cause harm and should not be screened for and should not be repaired prophylactically. Biliary atresia is rare but life-threatening, and consider early screening with total and direct bilirubin. But as we just said, much remains unknown about GI issues in heterotaxy, so hopefully more to come over the years. Thank you very much for your attention today.
Thank you very much, Dr. Tracy. We had some really great questions come in during that talk, so we'll get to those in a little while. Staying below the diaphragm here, we are going to ask Dr. Douglas McDonald, MD, PhD, Assistant Professor of Pediatrics in the Division of Immunology at Boston Children's Hospital, to discuss a little bit about diseases of the spleen.
Hello, I'm Doug McDonald. I'm one of the immunologists at Boston Children's Hospital. And I want to thank David and Tom and Stephanie for inviting me to participate in the Heterotaxy conference over the next couple of days. I'm going to present a discussion about immunologic management of patients with heterotaxy and asplenia, or polysplenia syndrome, and trying to keep these patients safe from overwhelming infections. So I will share my screen for my presentation today. So I just want to start off by stating that I have no conflicts of interest to disclose. So the goals of immunologists for patients who have heterotaxy and asplenia or polysplenia syndrome is to minimize their risk of infection. And obviously that can be influenced by the severity of their cardiac defects, the presence of asplenia or hyposplenia, as well as in a subset of patients, defective ciliary function. So our goal is to assess for the presence as well as the function of splenic tissue, and then to monitor these patients in terms of their overall immunologic function, with intervals as appropriate depending on the patient's condition. So the causes of asplenia are fairly numerous. It is estimated that there are approximately 1 million patients in the United States who are asplenic or hyposplenic. The more common causes of asplenia include trauma and surgical removal. There can be therapeutic reasons for splenic removal, including immune thrombocytopenic purpura, autoimmune hemolytic anemia, and hereditary spherocytosis. Fortunately, due to some of the advances in medical management of these patients, splenectomy is becoming a lot less common. Certainly, patients with sickle cell disease are well described to undergo a process of autoinfarction, leading to functional asplenia or hyposplenism. Less common causes of asplenia include isolated congenital asplenia and heterotaxy syndrome, which is important to us all here today. But there are numerous causes of asplenia and hyposplenism shown in this slide here. There are congenital forms, including asplenia, as we'll be discussing, heterotaxy, as we'll be discussing today, as well as a number of gastrointestinal disorders, hematologic and oncologic diseases, and immune deficiencies and immune deficiency syndromes can also lead to impaired splenic function, and a number of infectious diseases are well described to impair splenic function, and there can also be iatrogenic causes of impaired splenic function. Heterotaxy, as you are all well aware, can be characterized by left versus right isomerism. Left isomerism is also called polysplenia syndrome, and that is characterized by bilateral left atria, two bilobed lungs, and multiple spleens. Right isomerism, however, is characterized by asplenia, also referred to as Ivermark syndrome, is characterized by bilateral right atria, two trilobed lungs, asplenia, and tends to be associated with more cardiovascular malformations. So the spleen plays a really critical role in the immune function and normal host defense. It is a secondary lymphoid organ. Spleen functions include filtering blood to remove old, damaged blood cells and other damaged cells. It is also a critical site of immune responses to pathogens through both innate and adaptive immune systems. Roughly speaking, the spleen is divided into two main anatomical regions, including red pulp, which is a sponge-like structure where blood is continuously filtered in cords and sinuses, again, to remove damaged cells as well as to detect and remove pathogens. The white pulp is the site where adaptive immune responses occur, and that consists of CD4 positive and CD8 positive T cells in the periarteriolar lymphoid sheath. And it also contains follicles, which are a source of B cells. The marginal zone of the spleen contains dendritic cells, macrophages, and B cells known as marginal zone B cells. And these are a subset of B cells which function in a T cell independent manner, and they are able to mount prompt responses against a variety of viral and bacterial pathogens. So the infectious consequences of asplenia and hyposplenism are what we're most concerned about. Impaired splenic function can lead to overwhelming sepsis due to encapsulated organisms such as strep pneumonia, Haemophilus influenza type B, as well as Neisseria meningitidis. Encapsulated bacteria are protected from complement activation, and they resist engulfment by macrophages and neutrophils, and that is what makes them particularly virulent. Strep pneumonia has been shown to be the main cause of overwhelming post-splenectomy infections. Haemophilus influenza type B is the next most common infection, but other microorganisms can be problematic, including Pseudomonas, Capnocytophaga, Bartonella, and Babesia. Although the incidence of fulminant sepsis is fairly low at 3 to 7%, the mortality from sepsis is up to 70%. So very significant, very concerning. And the risk of sepsis is highest in young children under 3 years of age, as well as older adults over 60 years of age. So some of the techniques that we have available today to assess splenic function includes imaging such as MRI and CT, as well as abdominal ultrasound. This is the gold standard for diagnosis of asplenia. And it's important to note that spleen size doesn't necessarily correlate with splenic function. Functional studies include Howell-Jolly body counts in the peripheral blood smears. Unfortunately, this is a very insensitive way of assessing splenic function and is not preferred. The preferred method is an assessment of pitted red cell counts, and this can be sent to specialized labs. Our preference is to send to Cincinnati Children's Hospital. They have been quite reliable with quick turnaround times. The other assessment that we can perform is to quantitate IgM positive memory B cells. This particular population of B cells is predominant in splenic tissue, and decreases in IgM positive memory B cells can be seen commonly in patients with asplenia. So the pitted red cell count is an assessment of red pulp function. Review of the literature reports generally under 4% pit cell count in healthy individuals. Pitted red cell count greater than 4% is considered to be indicative of hyposplenism. As mentioned previously, we send our assessments for pitted red cell count to Cincinnati Children's Hospital. This requires 3 mLs of blood, refrigerated and shipped overnight. And their standard for normal range is considered less than 1.5%. So it's a bit more rigorous than what is currently reported in the literature. Lymphocyte analysis can be done at a number of immunology labs. We do our own assessments in-house here at Boston Children's Hospital. So we have a panel that assesses populations of naive B cells, as well as unswitched memory B cells and switched memory B cells. The production of IgM memory B cells from germinal centers outside the spleen may actually decrease the sensitivity of IgM memory B cells as a biomarker of splenic function. With time, patients will develop a relatively normal population of these cells due to production in lymph nodes. So a critical aspect of our management of these patients and keeping them safe from overwhelming infections is adherence to routine childhood immunizations, which is shown on the left here. And this will include immunization against strep pneumococcus, as well as Haemophilus influenza B. Nowadays, we have availability of Prevnar 20, which provides immunologic protection against 20 out of 23 of the serotypes of pneumococcus, which is significantly better than previous Prevnar formulations, which included only 7 or 13 serotypes. So this is a big step forward, and I think a wonderful development for protecting our vulnerable patients. When patients are greater than 2 years of age, we can further enhance their protection from pneumococcal disease by administering Pneumovax. The necessity of Pneumovax, sort of in the era of Prevnar 20, is probably not as important, but it can provide some additional protection. Also important is to provide protection against meningococcal disease. So for our patients greater than 2 years of age, we recommend Menactra. For children under 2 years of age, we recommend Menveo, which can be given in 2 doses in children 7 to 23 months of age. typically given at least 12 weeks apart. Our patients are also susceptible to group B meningococcal infections, and Bexsero is recommended for our asplenic patients once children reach 10 years of age. So we do recommend monitoring titers perhaps every 5 years and revaccinating as needed. It is also critical for them to receive yearly influenza and COVID vaccine because severe viral infections can be a setup for overwhelming secondary bacterial infections. So it's important to try to minimize risk of these severe viral infections. Another important aspect to keep in mind regarding these vaccines is that Menactra cannot be given with different protein conjugate vaccines because it can interfere with development of the immune response. So this slide just reviews some of the different options for meningococcal vaccine. As mentioned, for the younger kids as young as 8 weeks of age, Menveo can be given in a 4-dose series, or it can be given as a 2-dose series for older infants 7 to 23 months of age. Menactra is given to patients typically greater than 2 years of age, and Bexsero provides protection from group B meningococcus given to our patients who are greater than 10 years of age. Another important aspect of our management for asplenic and hyposplenic patients is antibiotic prophylaxis, which has been shown to significantly increase the incidence of serious bacterial infections. Two options include amoxicillin given twice daily or NBK given twice daily. For our patients who are allergic to amoxicillin and penicillin, alternatives can include macrolides or cephalexin. We also counsel our patients that they do need to receive immediate medical care following animal bites due to a risk of capnocytophagia infection. We also discussed the possibility of providing emergency antibiotics for fevers, including Augmentin at a dose of 45 milligrams per kilogram twice daily. And we also recommend peri-procedure prophylaxis with amoxicillin 50 milligrams per kilogram an hour prior to procedure. So also an important aspect of our visit with these patients is to review a fever protocol for asplenia and hyposplenia. We discuss with these patients that impaired splenic function can lead to increased susceptibility to infection with these encapsulated bacteria, and these infections can progress very rapidly and can be fatal. So our recommendation, which is fairly standard, is to seek medical attention for fevers greater than 101 degrees Fahrenheit or 38.3 degrees centigrade. And of course, if they have other signs of systemic infection, such as chills, rigors, vomiting, diarrhea, or headache, again, they should immediately be taken to an emergency department for evaluation and blood cultures. Typically, we recommend administering Rocephin or Unison to these patients pending negative blood cultures. For patients who have only mild illness symptoms consistent with viral respiratory tract infections without fever, they can be monitored at home. We also would recommend consideration of providing a prescription for Augmentin for patients who are remotely located and don't have rapid access to medical attention. They can start the medication at home and then proceed to the nearest medical facility that is available. So our standard immunologic assessment for patients with heterotaxy includes an in-depth review of their medical and surgical history, and reviewing imaging studies that are available to assess for the presence of splenic tissue. And typically our lab work consists of a CBC and differential, as well as an assessment of quantitative immunoglobulins, which include IgM, G, A, and E, and also a measurement of specific antibodies to pneumococcus, Hib, and meningococcus, as well as tetanus in our patients who have received their vaccination series. We also perform lymphocyte immunophenotyping, which includes memory T and B cells and marginal zone B cells. And this can help give us an assessment of whether or not there is intact splenic function, and of course, our preferred pitted red blood cell count. Follow-up for these patients can vary somewhat depending on the complexity of the patients. Typically, early on, we will monitor these patients yearly and then space out the visits as appropriate. For patients who may have had an immunologic assessment concerning for possible underlying immune deficiency, we will clearly keep an eye on them a bit closer. So some other immunologic considerations for our heterotaxy patients include the possibility of impaired T cell populations. And for patients who have the more severe heart defects and have required surgical correction and thymectomy, they can be particularly susceptible to T cell lymphopenia, particularly in patients who have had thymectomy under a year of age. Studies of these patients have routinely demonstrated reduced numbers of T cells, both CD4 and CD8 positive T cells, a reduced population of naive T cells, and a reduced TCR repertoire. Again, this is more concerning and more significant in patients who have undergone thymectomy under a year of age. The clinical significance of the T cell lymphopenia isn't absolutely clear at this time, and it will require further follow-up. But potential late effects can include premature immunosenescence of T cell compartments, and this can be exacerbated by viral infections like CMV, which is a very potent T cell activator, and it can deplete naive T cell populations, particularly in a setting where there is already a reduced population of naive T cells. And severely reduced naive T cell populations can theoretically result in autoimmunity, higher susceptibility to neoplasms, and increased infections. So possible ways that we can minimize these risks are to include minimizing the amount of thymic tissue removed and consideration of autografts of thymic fragments, although this is not something that is routinely done, but thymic transplants are performed in patients with athymia due to complete DeGeorge syndrome, and that has been very successful for those patients. So I hope you found this discussion of the immunologic management of heterotaxy patients with asplenia or polysplenia helpful, and I will be happy to discuss any questions that you may have at the end of this section. Thank you and enjoy the rest of the conference.
Thank you so much, Dr. McDonald. Your talk just really nicely illustrates the nuanced immunologic questions in heterotaxy and how they extend well beyond the question of whether or not to start or continue amoxicillin. Definitely an area well deserving of careful attention for all of our patients. So please allow me to welcome you once again to this wonderful multidisciplinary conference. My name is Dr. David Shidlow. I'm a cardiologist and director of the Heterotaxy program at Boston Children's Hospital, as well as the co-executive director of the Heterotaxy Research and Clinical Care Collaborative, along with Dr. Saba and Nisha Sabin. It is truly my privilege to introduce Dr. Jerry Marks as our keynote speaker today. Dr. Marks is a senior associate in cardiology at Boston Children's Hospital and an associate professor of pediatrics at Harvard Medical School. I have just a few moments, but I cannot overstate the profound impact that Dr. Marks has had on the heterotaxy community. And that impact has been through his remarkable clinical and research experience, along with his truly unparalleled dedication to caring for families affected by heterotaxy. It's truly nothing short of extraordinary. So please join me in welcoming my colleague, mentor, and friend, Dr. Jerry Marks.
I would like to thank Tom, Dave, and Stephanie for allowing me to participate in this very comprehensive program on heterotaxy syndrome. The title, Facing Heterotaxy Together, is very appropriate. The collegiality and dedication from the healthcare workers, the families and patients working together to face the challenges of heterotaxy is both essential and rewarding. In the next 20 minutes, I will share with you changes I have seen evolve over the past many years. The first are changes in the classification of heterotaxy syndrome. This is integral to diagnosis and treatment. Then I will share with you the improvements and outcomes for these patients. I will show you some of the medical and technological advances that have led to this improvement. And last, but most importantly, I will end by showing you examples of some of my wonderful patients with heterotaxy syndrome, whom I have had personally the privilege to be part of their care. I would like to spend just a few moments discussing the evolving changes in classification of heterotaxy. We were blessed at Boston Children's Hospital to have the two most noted pathologists, Richard and Stella von Prague. Richard would always proudly remind us that his wife Stella was Greek. When giving lectures on heterotaxy, he would always say that the word heterotaxy is from the Greek, with heterotaxy meaning other and taxi order or arrangement. As you have seen in the preceding excellent presentations, as we all know from Stella and Richard that have taught us many decades ago, that heterotaxy syndrome involves many organ systems, and most often the heart with profound implications. However, heterotaxy syndrome may not involve or have minor cardiovascular abnormalities, yet with a high incidence of morbidity and mortality. Stella and Richard, along with other pathologists, discovered that although the cardiac manifestations in heterotaxic individuals show considerable variability, there is a clustering of abnormalities that is associated with splenic involvement. From their autopsy studies, the spleen was almost always affected. The von Pragues hence defined a classification of heterotaxy syndrome based on absence or presence of a spleen. As shown in this slide of asplenia and the following slide on polysplenia, the von Pragues demonstrated that asplenic and polysplenic patients had important associated defects that help define this classification. Bob Anderson, a well-known pathologist in London, noted that the isometric pattern of atrial appendages could also define and classify heterotaxy into right or left atrial isomerism. Bob also delineated that the two types of atrial isomerism were associated with distinct cardiac abnormalities. There has been an ongoing debate on which terminology to be used, asplenia or polysplenia, or right versus left atrial isomerism. Yim appropriately evaluated in 114 patients with a heterotaxy syndrome by CT or MRI to evaluate the atrial appendages, bronchopulmonary, and visceral organ involvement. In summary, the classic pattern of classification were breached in 21% of patients. This study, similar to Yim and colleagues, we have also noted exceptions to the rule of absolute categorization of heterotaxy syndrome. Steve Sanders, head of cardiac pathology, and Tal Kiva, chief of cardiology at Boston Children's Hospital, wrote in their accompanying editorial that this study by Yim emphasizes the importance of an individualized approach to diagnosis based on a systematic segment by segment analysis of each part of the cardiovascular system. Now allow me to change gears to the other aspect I've seen evolve over time. That is the improvement in outcomes for these patients. This first manuscript dates back to approximately 25 years ago when Toronto Hospital for Sick Children reported one of the first comprehensive outcome analyses of patients with heterotaxies. The outcomes were in two parts. The first manuscript was on right atrial isomerism. Note on this slide that many had similar findings to those with asplenia. As you can see, reported in 1998 for patients with right atrial isomerism or asplenia, the 5-year survival rate was quite low at 35%, with a most marked drop-off in mortality within the first really year of life. Subsequently, in 2000, Toronto Sick Children's Hospital reported on their outcome experience with left atrial isomerism. Note that the similar anatomic abnormalities as those with polysplenia. In those patients with left atrial isomerism or polysplenia, there was a very high incidence of morbidity and mortality related to gastrointestinal disorders, including biliary atresia and malrotation, severe bronchopulmonary disease, neurological disease, and associated chromosomal abnormalities. For patients with left atrial isomerism, those that had a biventricular repair, their 10-year survival rate was 66%, and those with a single ventricle, the 10-year survival rate was lower at 38%. In patients without significant heart disease, the 10-year survival was still surprisingly at 80%. This was related to mortality related to the other organ systems involved. This improved survival for patients with a biventricular repair has been an impetus for our center to try and attain a biventricular repair when possible. Pooja Baka at Boston Children's Hospital evaluated changes in the prognosis of heterotaxy syndrome in 264 patients from 1984 to 2014. The overall mortality was 40.2% at a median follow-up of 10 years. In a multivariate risk factor analysis, factors associated with mortality included pulmonary vein stenosis, moderate to severe AV valve regurgitation, and univentricular hearts. Again, the factor with lower mortality included patients with a biventricular repair. Again, this data has been one of the driving forces to maintain a biventricular circulation when possible. In general, for all errors, the survival was improved from the earlier Toronto experience. As can be seen, the 15-year survival rate was 61%. Yet again, note a marked drop of survival in the early ages, with the second tapering in older patients. However, When subdivided to patients operated before and after 1991, in the graph to the left, there was survival improvement if operated after 1991. Graph C to the right shows that the 30-day mortality was improved over fourth errors. The next few slides are reviews of a more current unpublished outcome data at Boston Children's Hospital from 1980 to 2023. This graph depicts survival for 754 patients born since 1980 and diagnosed with heterotaxy before 2 years of age. The overall 15-year survival rate was somewhat improved at 65%. Again, the hazard of death is highest in the first year, with a more gradual decline after 15 years of age. This graph, however, depicts survival stratified by birth decade. Survival significantly differs amongst decades, primarily due to the high mortality of children born in the 1980s. There is evidence from the high hazard of death in early infancy observed in the 1980s and 1990s is reduced for those children born in 2000 and later. As seen from the graph to the right, the 1-year survival rate in 2020 was 89%. Even surgical outcome for heterotaxy infantile patients has improved. From 1981 to 2000, 135 patients were with heterotaxy infantile had a mean follow-up of 5.8 years. The 10-year survival rate operated with infantile before 1991 has improved from 70 to 93% operated after 1991. However, there was an increased mortality in those patients with total anomalous pulmonary venous connections and subsequent pulmonary vein stenosis. The improved survival for heterotaxy patients, however, can be attributed to recognition and treatment as it relates to associated diseases. Improved collaboration and expertise from other caregivers has been instrumental. At our center, we have a terrific heterotaxy team led by Dave Shidlow and nurse practitioner Caitlin O'Connell, who brings together the team of experts in caring for these patients. Improved imaging such as 3D echo, MRI with 3D rendering, computational flow modeling of AV valves, and CT analysis of complex valves with mathematical modeling aids in medical and surgical care. Cardiac intervention procedures such as dilation and stenting for pulmonary stenosis and conduit rehabilitation is instrumental. Electrophysiology interventions include intraoperative mapping, cardiac resynchronization therapy, continue to improve outcomes. And the advanced cardiac therapy team has been invaluable for their medical treatment of heart dysfunction, as many patients with heterotaxy syndrome have associated ventricular dysfunction. As mentioned, the improved outcomes can be attributed to advancements in such arenas as catheter-based interventions. Susan Foster and colleagues reported on the importance of total anomalous pulmonary venous connections and postoperative pulmonary vein stenosis. The survival has increased with catheter-based interventions for the pulmonary veins with dilation or stenting. Dr. Hoganson has already discussed the importance on computational flow modeling analysis for surgical planning for these patients. This slide depicts the alterations of the hepatic and vascular flow depending on how the vessels are surgically connected to the pulmonary arteries. This picture is from a recently published manuscript from the Departments of Surgery and Electrophysiology, detailing the use of intraoperative conduction mapping. The wire grid to the left is placed in the heart and maps the conduction system at surgery before going on bypass. The incidence of significant heart block requiring pacemaker intervention has been significantly reduced with this novel intervention. Understanding the complex anatomy of congenital heart disease is essential for surgical planning. These 3D echo images are taken from an infant with complex heterotaxy. The images to the left are taken during diastole and show the placement of the common AV valve well balanced over the right and left ventricle. The slide to the right is during systole and shows the potential pathway from the left ventricle to the aorta to this patient with double outlet right ventricle. This is 3D modeling, again, helping to comprehend the complex anatomy of heterotaxy syndrome. To the left, the VSD is outlined in green, and you can see the pathway from the potential ALV to the aorta bypassing the pulmonary outflow tract. To the right is total anomalous pulmonary venous connections to the LSVC in this patient. However, it is not just about survival, but quality of life. The following slides are from patients I've cared for either since birth, even in utero. All patients and families gladly gave permission to show the pictures and tell the stories. Ethan has dextrocardia, transposition of the great arteries, subpulmonary stenosis, and a status post biventricular repair. He is on medications for atrial flutter, and at some point will have a catheter ablation. Interestingly, that Ethan also had abdominal malrotation, but has had no surgery. He is now 8 years of age. He loves third grade and loves to roughhouse with his siblings. Grace is a lovely 25-year-old woman who graduated from college. She had double outlet right ventricle, complete AV canal, and severe LV hypoplasia. She had a last procedure and placement of a pacemaker at 5 days of age. She subsequently had a Fontan and has undergone ablation procedures for AV nodal reentry tachycardia. She is well adjusted, has a full-time job, and walks to her work, as shown in the slide to the right. As you can see in this picture to the left, at birth, Layla was born premature, small for gestational age, and jaundiced. She had a Kasai procedure for biliary atresia at birth and had a biventricular repair for transitional AV canal defect in infancy, including placement of a pacemaker for complete heart block. Despite mitral stenosis, in the slide to the right, you can see Layla is a delightful, engaging 14-year-old girl. She loves school and she loves being on the volleyball team. This adorable young man, Matthew, had this picture taken at discharge 1 week following a biventricular repair for a double outlet right ventricle, dominant RV complete AV canal, subpulmonary stenosis, and also total anomalous pulmonary venous connections. At discharge 1 week later, he was in normal sinus rhythm and an echo that only showed mild subpulmonary stenosis. The father calls me every several weeks to share with me that Matthew is doing just great. Patrick is a robust 16-year-old who was born with interrupted IVC, membranous VSD, subaortic stenosis, coarctation of the aorta, anomalous pulmonary venous connections. He underwent a successful biventricular repair and subsequent sutureless pulmonary vein repair for stenosis. Despite primary ciliary dysplasia, as you can see from this picture, Patrick stays very physically fit. And last, is Maya. She was born with the worst of possible diagnoses. She was born critically ill at 3.1 kilograms. She had surgery at 1 week of age for diaphragmatic hernia and a large procedure for malrotation. Cardiac-wise, she had a single ventricle, total anomalous pulmonary venous connections, and pulmonary atresia. She subsequently had a Fontan and catheter-based interventions for essential pulmonary vein and right pulmonary artery stenosis. Despite all of this, now at 16 years of age, she came to clinic and told me she wanted to be on the track team. Well, she had a normal exercise test. Her peak workload was 82% predicted. Her peak oxygen consumption was 77% predicted, which is phenomenally good for a Fontan patient. She currently loves being on the track team. So this improvement in overall survival and this improvement in quality of life has been made possible by the collaborative efforts and organized approach as together we face the challenges of heterotaxy syndrome. Thank you very much.
Thank you so much for Dr. Marks. I very much appreciate you putting faces to this syndrome, this condition that we all are fighting. Our roads are definitely difficult, and these patients are the reason we do what we do. And so without further ado, I want to introduce you to a couple of our moms that have different journeys, but we felt like highlighted some of the complexities of heterotaxy. So to begin with, we're going to have Jessica Dalton. Alice, her daughter, is a 4.5 or 4.5-year-old with right atrial isomerism and is preparing for her second open heart surgery. Life has been full with uncertainty and worry, but being surrounded by her twin sister, older brother, ponies, and life on the farm, Alice and the rest of Jessica's family have lived life to the fullest and found so much joy despite the difficult journey they have to face. Jessica and her family live in British Columbia, Canada. Jessica?
Hello, my name is Jessica and I'm from Chilliwack, British Columbia, Canada. My journey as a parent to a heterotaxy kid began in 2019 while pregnant to twins. I was given the news that one of my babies has heterotaxy, right atrial isomerism. We were given a list of 9 heart defects, abdominal organ abnormalities, and a possible list of other complications that could happen after birth, all common with our baby's diagnosis. We had a 1-year-old son at home and a healthy twin to consider, and what we were being faced with was unimaginable. My husband and I chose comfort as our priority for our baby, so we began having lots of conversations about palliative care after birth. On March 31st, 2020, the peak of the pandemic, I was induced at 38 weeks and delivered 2 precious babies, Emily and Alice. We were told to expect Alice to live just a couple of hours and to be quite symptomatic during that time, but she had other plans. Alice was born pink, screaming, and full of life. After a blur of 5 days in the hospital, wondering and waiting, we decided to go home with 2 babies in our arms. Alice continued thriving without any assistance. While comfort was still our priority, we shifted gears and decided to follow her lead on whatever path she showed us. As time went on, we started doing more testing. We realized she does have a functional spleen, doesn't have PCD or malrotation. The team at the hospital was very supportive of our approach to life with Alice and was right along with us when we shifted gears to full intervention. Alice had her first open heart surgery at 2.5 months old. She had the Glen and was home in 3 days, a textbook recovery. A few months after that is when life took an interesting turn and when my view of the care we received had shifted. Alice's sleep became beyond normal, waking every 45 minutes and screaming for hours straight. Her abnormal use of her left hand was dismissed. When she obsessively ate sand and dirt, I was told it was normal. Alice's SATs declined, her finger and toenails became more and more clubbed, and her coloring consistently got worse. I was repeatedly told there was nothing wrong. I fought hard and relentlessly and asked for second opinions. Eventually, a blood test was done and we discovered her ferritin was 1. She was started on an oral iron supplement, which led us down a long path of not much progress and an even more painful experience with her bowels and constipation. Eventually, her hemoglobin got so dangerously high that she had to be admitted on stroke watch. Alice was started on a high-flow IV drip, and once her hemoglobin came down to a safer level, they were able to do a heart cath, which is when they found she had a 16 mm venovenous collateral. They also did a phlebotomy and an iron transfusion. All of those things were a game changer, and Alice's life improved immensely. As even more time passed and 3 fragility fractures happened, I was told that her falling, clumsiness, and discoordination was normal. I knew it wasn't. Due to constant headaches, Alice was referred to a neurologist. The wait was long, but once she was seen, he was able to give her the diagnosis of cerebral palsy, which actually came as a relief to me. Validation that her physical symptoms were real. Our Canadian healthcare system has been spectacular in that we don't have to stress about how we're going to pay for Alice's care, or that we dreadfully have to deal with insurance to cover appointments or procedures. But in my experience as a parent to a rare heterotaxy kid is that our system is failing. Alice was treated and expected to fit inside the same box as every other cardiac kid. And even when I knew to my core that something was wrong, I was told that things were fine because the average cardiac kid follows a certain path. It hasn't really been until after the struggle of the first 4 years of life that Alice's primary care team has acknowledged that things don't go according to any typical plan, that they have to look at things differently and try not to fit her in the same box as everyone else. Alice is extremely sensitive to heart medications. Any dosage change or new meds and she will immediately become symptomatic, which has not been an easy adjustment to her doctors, but a constant reminder that heterotaxy kids don't always follow the same grain as other single ventricle kids. Through this journey, I have learned to stand my ground when I know something isn't right, or just even if I have questions that I want answered better. But also, in our country, we are a little bit stuck with the team and doctors that we have. Once referred for an appointment or procedure, the wait can be anywhere from 9 to 18 months. We only have one children's hospital in our province, and the process of seeking routine or surgical care elsewhere would include us to pay completely out of pocket unless our local team signs off saying it is not possible for Alice to receive care locally. With that being said, as much as I have learned to stand my ground, I also have to tread gently, as it is important that myself, Alice, and her doctors all have a positive relationship and not one of hostility or frustration. Understanding that balance is important and tricky to maintain. We have been repeatedly told that Alice's level of care and attention to detail wouldn't change, regardless of seeking other opinions, questioning, or being the squeaky wheel. However, when I have requested second opinions or pushed and expressed the difficulty of not being heard, I've been met with conferences with the specialists asking and wondering why I'm choosing the route of asking questions outside of our local children's hospital. Fortunately, with much discussion and explanation, myself and the team were able to come to a mutual understanding, and since then, I have felt positive entering and exiting any conversation or appointment. I'm a very hands-on parent, especially when it comes to Alice's care. I've made it very clear to every doctor that I want to know all of the details, even if they think it will be over my head, scary, or overwhelming. I want to know it all, and yet every time I have to prod for more information. I find myself constantly coming to the heterotaxy group, looking for others' experiences and leaning into the shared information, because I take that information, research it myself, and then can go into upcoming appointments fully prepared and with lots of questions and ideas. That alone has served us so well because it saves time during appointments and also so that after I don't feel the need to schedule follow-ups. Within the coming weeks, Alice will be undergoing her Fontan surgery, as well as repair on her common atrioventricular valve. With much anticipation and nerves, we feel conflicted that it feels unattainable to receive care at a hospital that has been most recommended. But we do feel very confident with Alice's surgeon that has spearheaded this next step she has to tackle. My husband and I are optimistic that with the support and work of the Heterotaxy Connection and community, that we will always have others with similar stories to stand in our corner. I know that with the progress that is being made to bring awareness to more doctors, medical professionals, and new families on this heterotaxy path about the complexities of this rare disease will only help us on our journey of advocating for Alice. Thank you.
Thank you, Jessica. We very much appreciate you sharing your story. Up next is Rachel Mattingly. At 19 months old, Owen has spent more time in the hospital and doctor's offices than most people will in their lifetimes. He has seen providers across more than 12 different specialties, undergone multiple surgeries, and most recently has been recovering from and doing great after his complex biventricular repair. Owen lives in Indiana with his family, and his mother, Rachel, will be sharing about their journey today.
Hello,
my name is Rachel Mattingly. My family is from Southern Indiana, and my son Owen is our heterotaxy warrior. In Owen's short 19 months, he has spent over 140 days inpatient, had over 170 outpatient appointments, and has established care across more than 12 different specialties. Needless to say, from the moment he was born, our family was immersed into the world of medical complexity. And today I'll be talking a little bit about some of the biggest hurdles that we've faced in accessing care. I'll share my screen. Okay. So when I sat down to really dive into what our biggest challenges have been, there were three main topics that stood out to me that are all pretty interconnected as well. The three being location of specialists and necessary travel, insurance issues and financial barriers, and provider availability / accessibility and breakdown in communication. To truly understand these hurdles, it's important to also first understand a little bit more about your average medically complex family. For many of us, at least one, if not both parents, have lost or given up their job or been forced to find a much more flexible job in order to become a full-time caregiver. For me, I was a full-time school counselor before the birth of my son, and I was only back at work for 1 week after my maternity leave before my son was back in the hospital, ultimately resulting in me losing my job. My husband too came dangerously close to losing his job back in July after Owen's heart surgery was unavoidably rescheduled for the 4th time, and he had already used all of his vacation. Circumstances like this often mean that financially, there are already barriers set in front of our families from not being able to hold traditional jobs. Unless you happen to live in a big city with a major children's hospital, travel also instantly becomes a necessary part of your normal life and budget, even if the money isn't there. For many of us, we often have to seek out specialists in more than one hospital as well, making multi-system care team communication, which is already difficult within the same hospital, that much more difficult and frustrating for families. I can't tell you the amount of times I've needed to relay information about something that has happened outside of one hospital system and in another, because the doctor I'm speaking to only has access to a couple lines written in a note that was sent to them with no way of accessing other pertinent labs, imaging, or more detailed information. Now, I know that these barriers of where my child's specialists are located, having to travel often, and running into insurance issues and financial strain are not things that providers can directly help with. But they're crucial to be taken into consideration when working closely with our families. And I'd like to give some examples why. Walking up to the front desk to schedule my son's follow-up cardiology appointment, the scheduler says to me, "Oh, I see that you have an ortho appointment around the same time that the cardiologist wants to see Owen again. He's not technically seeing patients that day, but I'll see if he can squeeze you in so that you don't have to make 2 trips up." The rare moments that that kind of courtesy has been extended to my family meant so incredibly much to us. The amount of money we saved in gas, lodging, food, and childcare for my other kiddo at home by not having to make a second trip is huge, and it all adds up. I've learned to start asking for schedulers to please do everything they can to lump a follow-up onto the same day as another appointment. And of course, I understand that that's not always possible, but having a team of people who are working with intention and consideration of our family's circumstances makes a world of difference for us. When it comes to provider availability and accessibility, I've also experienced rare moments where intentionality and exceptions to what the doctor normally does were crucial for my son. Like the time with my son's rescheduled surgery, resulting in us having to cancel a GI appointment that he had already waited 6 long months for. Initially, I was told that the next available appointment was another 3 months out. So I begged the doctor to please see us virtually instead, or even just call me for a quick 10-minute conversation, because we were dealing with big active GI issues that I didn't want to see my son suffer through for another 3 months. And thankfully, they made the exception. But for every doctor that has made an exception, there's one or more who didn't, or who couldn't because the system that they're working in isn't set up for it. Like the doctor who couldn't switch Owen's pulmonology appointment from in-person to virtual whenever Owen had a virus. That missed appointment was rescheduled for 3 months later. And again, I know that exceptions can't always be made, and the ideal scenario won't always work out. But in order to improve these hurdles for families, it's so important that we all come together to understand the lived experiences of walking down this medically complex path, just like we're doing right now at this conference. To understand the effects that these hurdles have not only on my child's health, but also on my whole family is huge in being able to then support and advocate for the families that you walk alongside as providers. And in a perfect world, a lot more intentionality would be woven into the structure of every major hospital system. For example, having a department specifically dedicated to complex care coordination who could help families navigate their loved ones' complex needs would be so beneficial to families like mine. The emotional and mental toll of being the only middleman coordinating all of my child's care often feels like a full-time job in and of itself. And I can't tell you how frustrating it can become to not ever have an opportunity to talk to multiple specialists in the same room at the same time about issues we're encountering that overlap into multiple fields. I pray for a day where maybe something will exist for us to be able to have a complex care conference with as many of my son's doctors on the same call at the same time to help us more effectively treat his multi-systems issues. Who knows, with enough people invested in these issues, just like all of you guys are today, maybe eventually we'll get there. I can't tell you how much I appreciate your willingness to step into our worlds and your desire to work together to improve these barriers that we face. Thank you, thank you, thank you.
Well, thank you very much to Ms. Mattingly and to Ms. Dalton for sharing those really touching stories, because of course, none of what we do, none of the science we do, none of the clinical care that we provide can be done without learning about the real life experience of patients and their families. Incredibly valuable, so thank you for that. So ladies and gentlemen, it is 9 minutes to 1 o'clock on the East Coast, and we are technically finished with the didactic content of today's conference. For the next hour until 2 p.m. Eastern Time, we will be fielding some questions that have been asked throughout the morning. Many of these questions were asked this morning, and many questions were submitted in advance by patients and families. Now, we've classified the questions based on maybe some general clinical and scientific questions and other questions that might be more specific to an individual patient or their family. Dr. Shidlow, Dr. Ware, and I will be going back and forth asking these questions. For faculty that presented today and those that are presenting tomorrow, we welcome you to unmute and to go on video to participate in helping us to answer some of these questions. Everyone is free to sign off if you choose at this point, but many of us will be staying on for these questions. Also, please kindly just unmute only when you're answering a question and to stay muted if you're not speaking. So I will go ahead and get started with the first question. I'm going to start with a question that was asked in advance by a family. And this question is as follows. By the way, the questions that were submitted and don't get answered today will either be answered tomorrow, or we will type a written response and send it out in a newsletter after the conference is finished. Okay, so question number one that we received in advance came from a family that asked, I'd love to know if Boston is the only center in the US that has a heterotaxy clinical care center. If not, where else can we find care? I might ask Dr. Shidlow to answer this question.
Yes, thank you. Excellent question. I know of at least one other dedicated program, and you've already heard from the director of that program, Dr. Steve Spurgeon, today, and you'll be hearing a little bit more about building a heterotaxy program tomorrow. As this community has grown, we've definitely appreciated that different centers have different approaches. Many centers have groups of individuals that are working together in various fashions. I think we all recognize that when there is a dedicated group that is working with a common goal and has a structured approach and a structured cadence of follow-up, that often seems to really benefit families. So I know Boston and now UT Southwestern, and I suspect that there are probably some others in various phases as well. And for what it's worth, this is something that we, meaning the Heterotaxy Connection and the Heterotaxy Research to Clinical Care Collaborative, would be very happy to help other centers and look for, in the next few months, a forthcoming toolkit which will help different centers to start building their own programs.
Dr. Shidlow, I might ask you then to carry on with the next question.
Sure. I actually might pose one to Dr. McDonald if he's still on from immunology. There was a question to the effect of when should an individual patient be able to stop amoxicillin? And if I can just say for a moment that even as a cardiologist, I get this question all the time. And I always say, well, this is a very nuanced question. Let me refer you to my friend and immunologist on the team, Dr. McDonald. So.
Well, that's a great question. And there's not a one-size-fits-all answer to this question. I would say that as an immunologist, we need to consider the patient in totality and what their risks might be. So we're going to focus on children who clearly have asplenia or impaired splenic function. I would say that it's worth considering discontinuing the antibiotic prophylaxis around 5 years of age if they're doing well and their antibody titers are all protective. That is, I think, a reasonable time to consider. Other centers, like in Europe and Britain, they will continue the antibiotic prophylaxis into adolescence. So there's not complete uniformity. But what I would say is it's important for people just to be aware that asplenia does represent a lifelong increased risk of bacteremia. So the fever protocol needs to be followed nonetheless. So is that helpful?
Absolutely. I think the key phrase there is that it's not a one-size-fits-all approach, and that each patient really merits their kind of own evaluation and guidance based on that evaluation. So absolutely very helpful.
Yeah, so I'll just say that it's been kind of a shared decision-making process that we have with families. And, so the issue is going to be maybe for kids around 5 or 6 years of age, they're entering school. So that group of kids is probably going to run into more febrile infections due to just exposure to viruses, right? So, that may be a situation where certain families might feel more comfortable continuing their antibiotic prophylaxis a little bit longer. So I don't dictate to families when to stop, but we all come to an agreement on, what the medical literature says and, their level of comfort.
Yes, Dr. Ware, you have the next question. You're on mute.
Thank you. I'm going a little off script here, but I just wanted to follow up on that on the immunology side, because I know there were a couple questions that dealt at the interplay between the pulmonary side and the immunology side in terms of sort of the long-term need and how quantitative immunoglobulins were used in that, in particular with patients that had PCD as well.
So is there a specific question or concern that in terms of immunologic function, or are we talking about just kind of monitoring?
I think the question was about monitoring, but it was, one of the questions from the families. And so I think a sort of a broad overview of that would be helpful. And then specifically for longer term surveillance, especially as kids get into adulthood.
Okay, fair enough. So typically what we do is we do in our initial assessments, when we see our patients, everybody gets an assessment of their quantitative immunoglobulins. So IgG, A, M, and E. And if they've been through their vaccination schedule, then we will do specific antibody assessments at that time. So depending on what we see there, may dictate what kind of follow-up we need. So if some patients will have low quantitative immunoglobulins, which we will continue to follow over time. If that remains low, we may think about what other interventions might need to be considered. So people who have chronically low immunoglobulin levels, if there's any impairment in their specific antibody production, we may need to consider immunoglobulin replacement, and that can be done subcutaneously or intravenously. And there are other issues that patients can have, like protein-losing enteropathies or chronic inflammation that can cause secondary loss of immunoglobulins, particularly IgG. So that's something that we'll keep a close eye on also. And if it doesn't correct over time, we may need to have a discussion about immunoglobulin replacement.
Thank you.
Okay, going back to one of the questions that was submitted before the conference, one person asked, why does heterotaxy happen? If the mom was exposed to maybe some type of exposure or drugs, if the genetic testing is negative, does heterotaxy happen as a result of some type of environmental exposure? And I might ask, I know Dr. Geddes is speaking tomorrow, but I might ask you to take this one.
Dr. Ware, do you want to say anything first, or?
Yeah, go ahead.
Okay. As a geneticist, I'm a little biased, obviously, but I think that a lot of these things, even when we call them sporadic, and they don't seem necessarily hereditary, they probably are mostly genetic in the sense of intrinsic. Surely there probably are environmental factors that affect risk, but I think for the most part, in the overwhelming majority of cases, these are things that were intrinsic and likely to develop from when the sperm met the egg. And for the most part, there's nothing anyone did to cause it or anything extra someone could have done to prevent it. So it's not like the coffee you drank, the vitamin you forgot to take, the 8 billion things that moms and dads, but especially moms, try to blame themselves for. This isn't something like that. So in the big picture of why does heterotaxy happen, I feel like that is a big philosophical life question that I can't answer. And even from a genetics perspective, most of the time we can't give you a great answer for why it happened current era. But I do think that it's primarily genetic or intrinsic, and we have other data to support that, including a higher heritability, just by observing families with heterotaxy.
Thanks. Maybe I'll shift gears a little bit and pose a question to Dr. Tracy that's come up in a few different forms in the chat and before the conference. I think it may come as a little bit of a surprise to some folks that screening for malrotation is not necessarily recommended, and that maybe even represents a shift from 10 or 15 or 20 years ago. So I think it would be great to hear a little bit more on maybe why that shift has taken place, and if we do any additional counseling for families on things to look out for, given that malrotation is so common.
Yeah, such a good question. It's definitely been a paradigm shift. I'm newer to the field, but from reading the literature, it seems like really over the past 10 years. And I think the change for not screening is because we know it's incredibly common. Most studies look at around 70%, but some studies quote up to 90% of patients having some sort of malrotation or non-rotation. And then when we look at the risk of actually having, a adverse event or a bad outcome from that, it seems incredibly low, down in the 1 to 5% range. So the risk of, screening everyone just to sit around and worry more is one thing. The screening generally is doing an upper GI study where, like what I talked about during the talk, a patient swallows dye and we take pictures to watch. A low risk study, but does have radiation exposure. So I think if we think that the large majority of patients, it's going to give us information that we're not going to immediately intervene upon, that is probably not worth the risk. That being said, because this population is at a higher risk of having some sort of intestinal rotation anomaly, things that patients and families should look out for are things like abdominal pain, vomiting, of course, blood in the stool, getting really distended or really bloated looking, are definitely things that you'd want to talk to either a primary care doctor or your heterotaxy team about, of course, a GI specialist if possible. And I will say most providers, I think, have this high on their radar for the heterotaxy group, and would know how to refer appropriately and get the right people involved if it seemed urgent, or if you're just worried about something about anatomy for another reason, it's worth talking to a GI doctor for sure.
Thank you. That's really helpful. And maybe I can just ask a quick follow-up question. My simple country cardiologist read of the GI literature, seems to suggest that there's actually some intrinsic risk to the lab procedure itself as well. I was wondering if you could comment on that and say how that kind of plays into the decision making.
Yeah, I wish Dr. Zendejas were here because he's the surgeon who does all these at our hospital. But I will say the risk, any abdominal procedure gives some risks in the immediate post-op period. Even for those who don't have heterotaxy, there's a risk of causing some adhesions, meaning that you can get another small bowel obstruction and it would have to go back in and reoperate on. Always risk of infection and other sort of causing other issues down the line when you're messing around with the intestines. So it's not a zero risk procedure. And like we saw in the heterotaxy group, it's actually a very high risk procedure for this group, all things considered, and which is why it's not routinely recommended any longer.
So there was another family question here that was to Dr. Buchholz. A 4-year-old with left atrial isomerism and no apparent heart issues, but they're wondering how there can be normal sinus rhythm and how can the patient have a sinus node with the left atrial isomerism, and would there be expected complications in the future or the likelihood of needing a pacemaker as a young woman?
Thanks for that question. That's a great one. We know that the diagnosis of left atrial isomerism kind of comes with various types of findings, at least in terms of the conduction system within the heart. And so there certainly can be absence or kind of under development of the sinus node. We can also see normal sinus nodes. And so it's certainly a spectrum. And the fact that it sounds as though there may not be structural heart disease in this particular patient, maybe lends itself to the idea that the sinus node in the heart kind of develops somewhat, overall normally in this patient. And therefore the risk might be lower kind of over
over the long term. I think, you know, and I don't think we actually have a EP talk specific to this conference, but there certainly is a decent amount of literature and thought as to kind of how much screening we should do as to kind of what the conduction system looks like in these hearts. I am by no means an expert in the electrophysiology or conduction system, and so I would kind of punt that to my colleagues there. But it's hard to know what to predict, and while there certainly may be a longer term kind of increased risk of pacemaker placement, and you know, globally in patients with left atrial isomerism, that's not uniform or by no means a rule for those patients.
Yeah, can I chime in and just add a little something on that particular group of patients? It's something that we encounter not infrequently. I see Caitlin O'Connell, our nurse practitioner for the program too, and I probably every 3 to 4 weeks bother my electrophysiologist down the hall and ask that very specific question. You know, this is my 13-year-old patient whose resting heart rate is now 52. Does she need a pacemaker? And in general terms, unless that patient is symptomatic or there's some sort of deleterious consequences with regard to the heart, you know, be it valve regurgitation or dysfunction, we tend to just watch it. So although it's absolutely possible, as Dr. Buchholz just said, much of the time we're just sort of observing it closely with periodic Holter monitors and waiting for patients to report any symptoms.
All right, thanks for that great question and a really thorough answer. We're going to move on to the pulmonary questions here. There was a lot of questions that came through during Dr. Garrett's talk, but I'll try to kind of put them all together and summarize. Okay, so basically, is there a spectrum of ciliary dysfunction, or is PCD a black and white diagnosis? In other words, do you either have it or do you not have it? And if there is some type of a gray zone in that spectrum, how do you find the severity of that gray zone? How do you look for that? If PCD diagnosis is relatively simple to make, how do you find if it's not PCD, but there's still something there?
All right, so I'm sure Dr. Saba is also going to have opinions on the answers for all these questions too, knowing he's a pulmonologist, so maybe we can tag team it, Tom. So the idea of a spectrum here. So in patients that have primary ciliary dyskinesia, genetically diagnosed, all of the arrows pointing in the direction of PCD, even patients with PCD can have a wide variety of presentations. Some of them are relatively severe, some of them can be more mild. And that gets down to even the individual gene that's causing a certain type of PCD. But stepping back from that, looking at our heterotaxy population, we see a lot of patients with heterotaxy that look like they have similar presentation to PCD, maybe not as severe, maybe the cough started later, but they can have similar complications without having a genetic diagnosis of PCD. And because of that, we think that there's probably overlap with this idea that ciliary defects are contributing to both disease states. Because of that, when you look through the PCD guidelines or how your pulmonologist is going to be treating these patients, it's going to be very individualized, right? So we kind of universally agree upon airway clearance. Airway clearance is a good idea, right, all the time. If you have a chronic wet cough, if you have bronchiectasis, we want to make sure you're expectorating your secretions. And beyond that, it gets very personalized for each individual patient. And that's why the workup tends to be pretty diverse in all the things that we can be doing. I know I personally, Dr. Saba, I'd be curious to hear what you say. I do a lot of chest CTs in kids that have heterotaxy that haven't had a chest CT since before their last surgery, for example, whenever they start getting chronic wet cough, and maybe they aren't having all the picture of PCD exactly, but I find a lot of bronchiectasis, which really dictates a lot of the treatment.
I think that's a great answer. I really don't have much to add. I know there are a number of pulmonologists on the call here, but clearly just because the patient doesn't satisfy the clinical criteria and diagnostic criteria for PCD, it doesn't mean that the cilia are 100% normal. And so the only way you're going to find evidence of ciliary-induced lung disease is to keep on looking for it. One of the families was asking about, should we be doing serial x-rays? Should we be doing repeated pulmonary function testing? I think yes. Even if you don't have a firm name or a label or an ICD-10 code to a disease, if there's clinical symptoms of coughing and recurrent pneumonias, we're going to want to know that and treat all those things and be on top of it. So it's a little unsettling that we can't really put a label on the kind of ciliary impairment that's not PCD, but it is a thing. It does affect people's quality of life, and it definitely needs to be addressed. Okay, Dr. Garrett, thanks for the answer.
Dr. Ware, do you want to pose the next question?
If you can go ahead, then I'll jump in a minute, please.
Okay, sounds great. So one of the questions, I'm paraphrasing a little bit, is about prenatal monitoring and prenatal involvement in terms of establishing heterotaxy care. And so I'm going to take advantage of the fact that Caitlin is on the meeting here, and maybe let her speak a little bit about her involvement in our maternal fetal care center and what that experience has been like. Caitlin, I apologize for putting you on the spot.
That's fine. Hi, everybody. It's been a wonderful morning learning from each other. We started prenatal consultations in the heterotaxy program about a year ago, and so far the response from families and clinicians has been very positive. So the rationale behind starting counseling that is heterotaxy focused in the prenatal period came from feedback from colleagues that, specifically, so I'm the heterotaxy nurse practitioner, but housed within the division of cardiology. So the fetal cardiologists who may be going through some really complex details with families when there's a prenatal diagnosis of congenital heart disease, and in cases where there's heterotaxy as well, having to delve into that as well. It's just really overwhelming experience for the family. So we started about a year ago, breaking out heterotaxy education. Of course, the fetal cardiologists do still cover it in their counseling, but I take the opportunity to meet with families prenatally, and we really dig in deep to get into some of the details, because as I'm sure many of you on this call can imagine, the experience and trying to learn everything that you can during the prenatal period can be really overwhelming for families. So I'll actually look at all the diagnostic testing that we have as of that time, and we'll go through specifically what we know about their child. Because as you guys know, just going out and Googling, some of these terms can be really overwhelming. So we kind of narrow down our focus in terms of what we know about that particular fetus. And then we discuss some of the care interventions that will happen pretty quickly after birth. And we found that presenting this information prenatally can make the experience less overwhelming for families, because those first few days of life, when they're meeting so many different care teams and kind of already being aware that, okay, we're going to meet immunology. Okay, they may want to do a nasal ciliary brushing on my baby. Okay, we may need to talk to genetics, after the baby is born, has been a pretty positive experience. So far, it's been a great experience for our families and for clinicians at the Heart Center.
Great, thanks for that. I know, Dr. Ware, you were dealing with some kind of computer issues, so I'm happy to take on the next question. Okay, so let's go back to immunology here. We got a bunch of questions about immunology. So this is for Dr. McDonald. Right, so here we go. So some people are asking questions about polysplenia. You were really clear on what hyposplenism means from a functional perspective, but let's say somebody is diagnosed with polysplenia and maybe the function of that spleen is not really clear. Some of these diagnostic tests are not perfect. So would you recommend approaching polysplenia the same way you would approach asplenia, with antibiotic prophylaxis and fever management and all those things?
Yeah, that's a good question. So, I think the bottom line is that there's no perfect test to assess splenic function, but assessing the pitted red blood cell count and looking at some of the different lymphocyte populations gives us a good idea of what's going on. So I think our approach has been that for these patients, we try to make sure that they're up to date with all of their immunizations. And if their specific antibody production is normal and their measurements of splenic function are within normal range, so they have visualized splenic tissue, and the pitted red cell count and lymphocyte populations are all what we expect them to be, then I think we can discuss discontinuation of antibiotic prophylaxis in that setting.
Okay, while I've got you on the line, there was another really pertinent one that I might just kind of slip in here before I move it on to the next person. Okay, so there was a pretty good discussion on the chat about pitted red blood cells. So what is the diagnostic value of pitted red blood cells in a patient who has received a blood transfusion? And that pertains to a lot of patients, in the cardiac ICU after surgery. What's the value of pitted red blood cells after transfusion?
That's a great question. So what are pitted red blood cells exactly? So those are red blood cells that have little sort of accumulated old dysfunctional proteins, which cause these little what's called pits. And the function of the spleen, the red pulp, is for the macrophages to remove that material from the red cells, and then they're released. So if there's a lack of splenic function, there's going to be a greater percentage of those pitted abnormal red cells in the blood. So that's what we're looking for. And I'm sorry, what was the exact question?
Oh, what about somebody who's received a blood transfusion?
Right. So that's one of the criteria. We don't want them to have to send off a pitted red count within about 90 days of receiving, because that's going to falsely lower if there is impaired splenic function. So that's a really important question.
Thank you.
And can I just follow up on that and ask a question about spleen scans versus using pitted red blood cells? And is that, are there, in your mind, definite guidelines around that, or is that a nuance in terms of making a formal diagnosis?
Right. So we used to do these radioisotope spleen scans, basically, and those labeled red cells would be uptaken, say, in the liver as well as any splenic tissue. But it shows you spleen uptake, but it doesn't really give you an assessment of splenic function. And it's exposing the patient to radioactivity. So the gold standards have shifted more towards the pitted red blood cell count as well as the lymphocyte immunophenotyping.
Thank you.
Going after Dr. Ware too, I have another question if possible. So many of our patients who have heart surgery early get a partial or sometimes total thymectomy. And just based on my experience with 22q patients or some of the patients who get really early surgery and might even come back with an abnormal skid screen, it seems like their lymphocyte numbers are off for a number of months after surgery, after their thymus is surgerized. And so I was wondering what you think of that and when you start using those numbers.
Right. So that's a great point. And it's one of the things I was mentioning towards the end. I didn't have a lot of time to go over it, but it is very common for a lot of our complex congenital heart surgery patients, not just heterotaxy, but they all undergo some degree of thymic removal. And that can cause a T-cell lymphopenia. I think the vast majority of those kids do well lifelong. And as long as they have a reasonably good naive T-cell production, which is something that we look at for those patients, they tend to do well. But there will be a subset of patients who, if they've had thymectomy early, particularly in the first few months of life, they may be more susceptible or more likely to have more severe T-cell lymphopenia. So those are the patients that we typically will follow a bit more closely in immunology clinic.
Maybe I could pose another question if it's okay to Dr. Tracy. I think that one of the things that we always hate to miss is biliary atresia, and also something that we are increasingly cognizant of is portosystemic shunts or Abernathy malformation. And while both of those are rare, they can obviously be quite devastating. So I was wondering if you could revisit for us kind of our institutional approach and when we should start looking for those types of things.
Yeah, it's really hard. So biliary atresia is a really tricky one because like we went over, survival and transplant-free survival is much higher the earlier that it's diagnosed and the earlier that the Kasai procedure is performed. And unfortunately, there aren't a lot of clinical signs or symptoms until the disease is very advanced. That one study we went over is looking at, do we starting to screen all infants with both a total bilirubin, which is a pretty standard screen, but also a direct bilirubin at the time of birth, which is sort of more liver specific. I'd be curious to see what happens in the next few years if that really becomes part of the practice. You'll have to tell me, actually, Dr. Shidlow, here, do we screen all infants with a direct bilirubin? I'm not sure if that's actually part of their sort of like standard heterotaxy screen, but I think it's a good idea considering they're a high risk group.
Certainly for the ones with polysplenia, since that seems to be the bigger association.
Definitely.
And actually, Caitlin, you can also comment on whether we're doing that routinely for polysplenia or for all patients across the heterotaxy spectrum.
Right now, just for the polysplenic patients.
Which I think makes sense because that, biliary atresia splenic malformation group, it's really polysplenia and intrepid IVC, excuse me, that are the highest risk patients.
Switching to the lungs, there's a question about the need to do lung function testing on someone with right atrial isomerism, lung morphology typical with RAI, but not diagnosed with PCD. And then, maybe the broader question from that is just in individuals with heterotaxy, what are the recommendations regarding pulmonary function testing and how has that been incorporated into the longer term management?
I think that we probably under test all of our congenital heart disease patients when it comes to pulmonary function testing. We know from the studies that have looked at this that most patients with congenital heart disease will have some decrease in their pulmonary function, usually a restrictive defect. I think the hard part is to know what to do with it. I think establishing a baseline is always helpful. And if I remember that question coming through, there were questions about how does the pulmonary function reflect on the cardiac function? And it's hard to tease the two apart, right? It's hard to know when the reason that the patient is having decreasing pulmonary function is because of advancing issues with their different cardiac procedures upcoming. So, in general, I think we should probably be just tracking it more often as another objective measure of how the patient is doing. It's difficult to do, especially in these younger kids, right? A lot of these kids that are getting these surgeries are too young to perform PFTs. But in the older kids, we could be tracking them more often. Obviously that changes if the patients are also having pulmonary symptoms. If the patient has primary ciliary dyskinesia or bronchiectasis, we'll use that data differently. But there could be more testing than there currently is if there's capacity where you practice.
And sort of as a follow-up to that, in patients with PCD as well as asplenia, do you find that there's more difficulty in terms of managing the long-term complications from an infection standpoint, the bronchiectasis and so forth? Is it sort of the more typical infectious agents that you see with that, or does the how does the asplenia and the PCD complicate things essentially from the immune standpoint and the lung management?
I think the probably political answer to that is the more things you have going on, the more complicated things get as far as the management goes. I personally don't know of any data specific to management of primary ciliary dyskinesia in the context of splenic dysfunction. Also, We've heard about the varying degrees of suppression of the immune system that you might experience based on the type of splenic dysfunction you have, and that's going to layer on top of all the other things too. How complicated was your congenital heart disease repair? How many infections did you have when you were on the ventilator in the perioperative period? I think most of these patients and one of the mothers spoke to just complex care in general. The more people you can get in the room thinking about these patients at the same time to put the big picture together, I think is helpful. But I don't know, Dr. Saba, unless you know of any specific data on infectious diseases in the context of PCD and splenic dysfunction.
I don't think we know that.
We do have a PCD registry though. It's in its infancy, and a part of that is collecting this type of information, and it is in the power of big data that hopefully we'll be able to get some of these answers.
The interesting,
We don't have, anecdotally have not seen patients with that, but we, on the heterotaxy side, have not had, surprisingly, that many patients that have had a PCD diagnosis. I think that we should have more than what we do, either molecularly or by high-speed video microscopy.
So Adam Shapiro's bringing a comment into the chat here that says that we really have very few PCD patients with right atrial isomerism. Could be that their case is so severe that they might not survive to the PCD diagnosis. So that's a thing. I mean, in people who have PCD, we have a pretty good idea for what proportion of them have heterotaxy. It's probably about 25%, and 25% have other forms of laterality defects like sedis versus totalis. What we don't know is among all the heterotaxy patients, how many of them have PCD? We have no idea. So, of course, one of the main goals of the heterotaxy registry, which is going to happen someday, is to actually figure out what's the prevalence of PCD in this population. I mean, we are actively recommending testing for PCD, but how much of a, what's the positive predictive value? We don't know. It's definitely something we need to look into. Adam Shapiro adding a few comments here. Outcomes in PCD are worse when there are splenic defects, more respiratory and GI morbidities. We're going to actually be hearing about a case tomorrow that illustrates this point quite well. So I might throw a question back to the cardiology team here, all the cardiologists on the call. A few people are asking about specific surgical techniques. And I know Dr. Hoganson had some really, really nice slides about really precision medicine and how to do the surgical operation according to the patient-specific anatomy and flows and things like that. But a lot of people are asking, what's the difference between a biventricular repair and a single ventricle repair? How do you make that decision, and what might be some of the long-term outcomes of that decision?
Sorry, that's a great question. It's a really hot topic within cardiology. And I think, we were talking a lot about patient-specific anatomical characteristics, and there's no more patient-specific consideration than this one, whether or not a patient is a good candidate for biventricular versus single ventricular repair. Our program is gotten started up in the last year or so here at Southwestern, and we are tracking outcomes and doing similar analyses with modeling via MRI and trying to predict which patients will respond, which ventricles will grow and be good to ventricular candidates. And so, it's hard to make a blanket statement there, but I think it's definitely, definitely the question, is it better to be a good Fontan or a two ventricle repair? It's an active area of research and learning, and something we think about on a daily and weekly basis.
I'll reiterate kind of what Steve said, that, the decision is incredibly nuanced. I think that there are some obvious cases where we know that we are not going to be able to septate a heart and make it a biventricular repair just based on the anatomy that's, the native anatomy. And then there are some where it clearly would be a fantastic biventricular repair and there's no need to go down a single ventricle palliation route. And then there is a lot of gray, and that gray area is, as Steve mentioned, a very active area of investigation across the country. I think, and with some of the newer surgical techniques that have come out, I think we're trying to push the boundaries on who is ultimately a candidate for biventricular repair. The other point that I guess I will add is that, if in the absence of heterotaxy, single ventricle palliation may be a really good option for some patients, but there are some nuances about heterotaxy that kind of make some patients less amenable to single ventricle palliation. And so one of the physiologies that we kind of mentioned is in the setting of an interrupted IVC. We know that those patients who ultimately undergo a Kawashima operation, which is where there's kind of a second stage procedure of a single ventricle palliation, are at higher risk for developing pulmonary issues. And so in those patients, sometimes there is more of a pressure to kind of try to push them towards a biventricular repair if we think we're going to be successful in doing so. So there's certainly kind of overall nuances, just the decision regarding single ventricle versus biventricular repair, but then also in patients with heterotaxy that it may even be more nuanced based on what the underlying anatomy is.
Maybe I'll chime in very briefly. I couldn't agree more with both Steve and Emily that it requires a very careful, individualized assessment for each patient. Another thing that I would add is even within single ventricle and biventricular repair, surgical interventions for heterotaxy are quite variable, and either pathway requires a very careful assessment. Dave Hoganson, who unfortunately happens to be in the operating room at the moment, illustrated that beautifully with the Fontan example, knowing how the Fontan flow is going to be distributed to both the right and the left lung. It's a critical question, lots of active research. And on the biventricular side, very careful planning, knowing not just the size of the ventricles, the position, the size of the AV valves, what's going to be involved in that reconstruction, all really important questions. So it's more a single ventricle versus biventricular, important question. But even once you get to that point, there's so many details and nuances to each individual patient. I think it might be my turn to pose a question. So I'm going to move laterally in the thorax back to the lungs and pose a question to the pulmonary folks. We've definitely observed that our heterotaxy patients often have gross morphologic lung abnormalities. So obviously we see the bilateral right and left bronchi quite a bit, but we've also noticed patients with unilateral or sometimes bilateral tracheal bronchi. And I'll admit that we do not necessarily screen for that. Not every kid gets a bronch or whatever the appropriate test would be, or a CT of the chest. And I'm just curious if the pulmonologists have any thoughts on that, or if it's something that we should be screening for a little bit more carefully, or just general impressions overall about gross airway abnormalities.
I think Dr. Shidlow, like you said, we see a lot of, where there's cardiac anomalies, a lot of times there's airway anomalies. What we can do about it is probably the reason we don't screen more often. So I certainly wouldn't sort of blanket recommend bronchoscopy in all of these patients, but if you have a patient that is symptomatic, certainly if you have a patient that might be able to have some sort of intervention and is symptomatic, that much more of a reason to go looking and see the best way to support them. The other issue that we will see after certain surgical interventions is airway compression, right? You go in there, you change anatomy, you move things around, we'll get a fair bit of bronchial compression, or after heart transplant or otherwise. Usually that helps just push us toward different modalities for airway clearance or positive pressure ventilation if the patients are having that big of an issue. But when it comes to airway anomalies, it's not like there's sort of any operative course that we can take where we turn your anatomy normal again in your lungs and your lung branching. But good to understand whenever patients are having persistent atelectasis of a specific lobe, for example.
I was just asked if I saw the question about study updates in the chat, which I didn't. But I will say that we do have a study ongoing here for the genetics of heterotaxy for anyone who is interested. We have through the Gabriella Miller Kids First program at the NIH have gotten whole genome sequencing on a large cohort of patients with heterotaxy or heterotaxy spectrum cardiovascular malformations. So we have that data back now on about 550 individuals with heterotaxy or heterotaxy spectrum CHD. And about 100 of those are as trios. So we have both parent samples as well that we have whole genome sequencing on. And so the goals of that study are to identify new causes of new genetic causes of heterotaxy, and then also to try to be able to find some modifiers or be able to link some of the genetic bindings that we see with particular phenotypes. So we have really good anatomic information for all of the patients that are enrolled in the study. And we should have some more data coming out on that soon in terms of the findings. If we do find a clear, unequivocal genetic cause for heterotaxy, in the individual that's participating in the study, then we do report that out to them. So for example, if they have not had genetic testing for PCD and we found clear evidence of PCD molecularly, that would be reported back to the family with a recommendation for that to be sort of validated and verified at their own institution. But we're open to for their individuals that are interested. And certainly if and when we have the registry going, this has been such a motivated set of individuals that are participating in these studies. And we would be happy to link the genetic findings with the registry for patients who have consented to be involved in both. So hopefully that answers some of those questions. And then moving on to the question I was going to ask, it was for Dr. Tracy, and more questions kind of related to screening and surveillance, and then also the lab procedure. So there was a question for understanding that that's no longer current practice, but for older individuals who had a lab procedure done, is there any specific concern there that needs to be followed over time, or any surveillance that needs to be done? And then related to that as well, a question of understanding that the lab procedure is no longer done and the reasons for that, but is there a reason why just screening wouldn't be done so that at least the anatomic details would be known and families would be given that information?
I think unfortunately Dr. Tracy had to step off the Zoom to go see patients. And I certainly am not experienced enough to comment on a long-term follow-up after lab, but maybe Caitlin can share. It is our practice to assume that patients with heterotaxy have malrotation and to give them appropriate guidance in terms of what to look for, but maybe I'll let Caitlin share more detail.
Yeah, I do. We include that as part of our routine teaching with families, whether or not a diagnosis of intestinal malrotation is known, that there's a very high risk that their child may have malrotation, even if they're asymptomatic. And we go through the signs and symptoms that Dr. Tracy reviewed in her presentation: abdominal distension, abdominal pain, and bilious vomiting as the key signs that would get that would necessitate an urgent evaluation in the local emergency room, in the closest emergency room. So yes, whether or not somebody has had a LAD procedure, there is still a risk because it was an abdominal surgery. There's a risk even in children who have had a LAD procedure of a future intestinal obstruction. So whether or not we know that you have malrotation or not, and whether you've had a LADS or not, the education that we provide to families is always the same. And that is just making sure they know of those signs and symptoms.
So also not being a GI doctor, my bias is that a lot of times when we image and find the malrotation, people want to react to it more. And so if we're trying to say, you know, if you're asymptomatic, you don't need intervention and emphasize that, sometimes they'll be like, oh, I was looking through the chart and it's, you know, says you have malrotation, we should really send you to a surgeon. And that might just be my own experience and my own bias, but I feel like sometimes it works against us to have that documented because then people really want to act on it, which for our kids seems to not be the best course.
Okay, folks, so it is 1:15, and it looks as though we've made our way through the vast majority of the questions. There might be just a couple questions left over that we can roll into tomorrow, and if there's anything that doesn't get asked, we'll make sure to send a newsletter out to make sure that everything gets addressed. In an effort to not get too burnt out, we might end at this point today. And see each other first thing again tomorrow morning. And I think today was just really quite inspiring. And for those that presented, those that researched, those that participated, those that asked and answered questions, and the families that shared their stories with us, we want to extend our sincere gratitude. Hope everyone has a wonderful rest of the day, and we look forward to seeing you all tomorrow morning.